So this is the activity targeted towards the students and their exam preparations. We started this last year, and we did two such meetings last year also. So this time, Dr. Girdhar Bora has taken the initiative to continue with the same program, and I would hand it over to him to start this program now. Dr. Girdhar, please.
Yeah. Good morning, everyone, and happy Republic Day to everyone. Thank you for joining us today, Republic Day morning. And it's a unique webinar focused on resident training. It has 5 sessions. First session will be a case discussion. It's kind of a ward round. We do it in the exams when one of the residents from Dr. Rajath will be presenting a case, and 2 residents, Dr. Surendra and Dr. Jaipur. Surendra is from Varanasi, and Dr. Jaipur from AIIMS Jaipur will be treated as a exam going residents, and the examiners for today are Professor Mandal, Dr. Nachiket Vyas is unfortunately not able to join, and Dr. Ravimohan and Dr. Uday Pratap will be as an examiner. And the next session we will keep on updating. So now we can start with the first session, that is a clinical case presentation.
Just a moment. Dr. Sawal has just joined. Maybe we can have his word before we start. Dr. Sawal, sir, please.
Good morning, everybody. I welcome you all for our first assembly of student session, resident session. Since I am in travel and signals are weak, I wish our very best to
I think, sir, unfortunately lost his connection. Yeah.
Okay. Thank you, sir. Carry on, please. Yeah.
Okay, so the first session will be a case presentation by Dr. Rajath, and I think I request Dr. Ravi, Dr. Uday, and Dr. Mandal to take over from here, and they can take the case as it goes. Thank you. Dr. Rajath, please.
Sir, is the screen visible, sir?
Yes.
Yes.
Make it full screen.
Yes. Yeah, just a second. It is full screen now, sir?
Yeah, I request everyone to mute their speakers, and you can switch off your video so that we can have a better stream. Only the session moderator, residents, and the examiners can keep their mics on and videos on. Rest all can make their mics mute. Dr. Rajath, thank you.
Dr. Rajath,
Yeah. Good morning, everyone.
Full screen, actually. It's not a full screen.
It's full, sir. Yeah, I have done it full screen only, sir.
Make it slide share, full share.
Yeah.
Just a second, sir.
Yeah, no, you lost your presentation. You share it again.
Yes, sir. Yes, sir. अभी full screen आ रहा है, sir?
अभी भी नहीं आ रहा, but
No, but chalo, let's continue.
We'll manage. I think we just start.
Just start.
Okay, good morning, everyone. I am here presenting a case of a 61-year-old male resident of Rajasthan and an occupation and a farmer by occupation. He presented to us with painless gross hematuria for 2 months and acute urinary retention for 15 days.
Rajat, your slides are not moving.
Is it moving now, sir?
Now, yes, it's moving.
Make the left.
I don't know. Actually, in full screen mode, it is not moving ahead. Sure.
Yeah.
Yeah, but make the left.
So whichever mode, just continue.
Yes.
Yeah. Coming to the demographic details of the patient, he is a 61-year-old male, resident of Rajasthan, and a farmer by occupation. Coming to his chief complaints, he presented with painless gross hematuria for 2 months and acute urinary retention for 15 days, since 15 days back. Coming to the history of presenting illness, the patient was in his normal state of health until 2 months ago when he developed painless gross hematuria with serpentine clots. There is history of generalized weakness and a significant weight loss of approximately 15 kgs over 6 months. And there is a history of acute urinary retention 15 days prior, and there was a catheterization done, and there was stat approximately 800 ml output with accompanied by hematuria. Patient also complains of mild dull aching pain, which is not very significant and not very bothersome to the patient. There is also history of generalized weakness and significant weight loss. There is no history of fever, cough, or breathlessness, no pain or no bone pain or yellowish discoloration of the eyes or urine, no history of vomiting or fever, no stone passage, no or trauma, no history of blood thinners or facial puffiness, no respiratory or systemic symptoms like chest pain or bone pain. Coming to the past history of the patient, he is a known case of COPD, known case of type 2 diabetes on medical management. There is no history of TB or any other comorbidities. There is a history of IND done for scrotal abscess 5 years back, and there are no history of any other surgeries for the patient. Coming to the personal history, a family and personal history. The patient passed away due to natural senility, and though there is no history of cancer or any other diseases in the family members. Uh, Coming to the personal history, he is married since 29 years with spouse and children are healthy. There is a history of smoking 20 BDs per day for 15 years. He has stopped from 5 years. There is also history of reduced appetite, but normal sleep and bowel abscess are normal. Coming to the general examination of the patient was conscious, cooperative,
I think
oriented with a
Rajat, you can
turn-off.
stop there, and the examiners
Yeah.
can check upon the residents. I think Dr. Surendra and Dr. Jaideep are there for the exam case. They can discuss with the exam. Yeah, examiners.
So, Surendra and Jaideep, one of you maybe can answer. What are your initial thoughts on on the history, entire history?
Hello,
Sir,
good morning.
Morning, guys.
yes, good morning, sir. Myself, Dr. Surendra, sir. 61-year male patient presenting with chief complaint of gross hematuria and flank possibility is renal mass. Second possibility is upper tract urothelial cancer. Third possibility is renal stone.
So,
And
sir, I would.
Yeah, Jaideep.
fourth possibility
Sir,
is cystic disease.
Dr. Jaideep and Dr. Surendra, please switch on your camera so that examiners can see you and we can have a better discussion. Thank you.
sir, sir, it is showing that the host has disabled the video. So, sir.
No. Now you can. Yeah, you are. We can see you.
We can
Okay,
see
sir.
you.
So, sir, since a 60-year-old male patient who has a history of smoking, chronic smoking, and has presented with a progressive history of hematuria, first of all, I would like to keep a malignant diagnosis of the upper tract since he's complaining of serpentine clots also in his hematuria. So, as Dr. Surendra rightly, I think, has put a differential diagnosis of renal mass, like an upper tract urothelial malignancy. So, UTUC or renal mass more prevalent, so that should be our first diagnosis. And
So, renal mass, and you said somebody said stone, right?
Yes, sir. Stone would also be third possibility, and the cystic disease also may be considered as a fourth possibility.
Cystic disease. No, don't give possibilities which you cannot justify.
sir,
Simple.
a
In exam,
carcinoma
just
bladder.
keep. Yeah. So bladder cancer should come as one of the possibilities. Serpentine clots, these are not. I mean, you cannot be so specific about this nature of clots, and don't value so much on the nature of clots, serpentine and non-serpentine. So bladder cancer still would be a possibility. So I would say RC, upper tract malignancy, either RCC, TCC, and bladder cancer, because the rest everything is fitting into malignancy pattern, right?
Yes, sir.
So even if you keep stones, even if you don't keep stones, it's fine. It's not essential that you keep on adding the list and then getting and not able to justify. Dr. Uday?
So, how are you going to define if you are making a diagnosis of CA bladder? So, how will you explain the flying pen in that case, actually?
So the tumor, there are two possibilities in bladder cancers. The tumor either might be involving the VUJ, and might be causing obstruction, which might be leading to the flank pain first, sir. Or the second, the tumor might be obstructing the bladder neck, which might be causing upper tract changes, or a muscle invasive disease might be involving the VUJ, which might be causing upstream hydronephrosis, which might be explaining the pain. So that is one possibility I would like to.
What else? Sometimes, very rarely, you can find the upper tract TC as well with the same bladder.
Concurrent one, yes.
Yeah, concurrent. You can. That is not that much common, but still you can find it.
Yes.
Sir, Mandal sir, you like to add something?
No, discussion is fine, but just a ureteric tumor also will be an upper tract TCC, and it can cause everything.
Yes.
Yes, sir.
So bladder tumor, as Dr. Ravi correctly suggested, should always be kept as possibility. We should not rely so much on the history of serpentine clots. I think go ahead.
Okay. So
Dr.
let's move
Rajath.
on then.
Yes, sir.
Rajath.
Yes, sir. Coming to the general examination, the patient was conscious, cooperative, oriented with a Karnossi score of 90%, and vitally he was stable. The blood pressure was 126 by 78 millimeters of mercury. Pulse rate was 80 beats per minute. Respiratory rate was 18 cycles per minute, and he was afebrile. His height was 188 centimeters, and his weight was 67 kgs, and a BMI of 19. He had pallor, and there were no other positive findings. No icterus, no pedal edema, no clubbing, or no lymphadenopathy was seen. Shall I move?
Yeah.
Yeah. Coming to the systemic examination, the abdominal examination, inspection. On inspection was normal in size. The umbilicus was central. No pigmentation or squaring. No visible veins no visible veins. Coming to the palpation, it was non-tender, no muscle guarding or no renal angle tenderness, no mass or no organomegaly was there. Coming to the percussion, tympanic note was present and auscultation bowel sounds were present. Coming to the respiratory examination, bilateral air entries were present and there were no added sounds. And cardiac examinations, normal heart sounds were present. Coming to the local examination, bilateral testis was normal and there was no evidence of varicocele. And DRE showed a grade 1 non-nodular prostate with normal mucosa.
Okay.
Should I go?
No. So Jaideep, you want to know anything else, or this is complete?
So this appears to be complete, sir. The abdomen has no significant findings, and the flank has been examined in the examination. The genitalia have been examined, and there is no significant finding there also. I would have examined the chest, and that also has been done. There are no added sounds in the chest. So, and they have the completed examination by doing a digital rectal examination also. So this does not give me any added information to my to make any provisional diagnosis to my differential diagnosis, but the examination appears to be complete, sir.
Surendra, Dr. Surendra?
Yes, sir. It's fine, sir.
That's fine, huh?
Is
Dr.
the
Surendra,
patient still on urinary catheter?
No, sir. The catheter was
Okay,
removed later.
okay, fine.
So
In
we
case the
all,
patient was on
yeah.
catheter, then you must mention the catheter, the meatus, and the epidemiologitis. These must be seen.
Okay, sir. Yes, sir. Sure.
Yeah, so we all missed that part of the story that he was catheterized, and then we never inquired about it. So I think we all missed it. Just remember for exam, do ensure that whatever has happened, you keep a follow-up of it. Better to write it on paper so that you tick mark all of it. Okay, the catheter was there. What has happened? Like sir has actually pointed out what has happened to the catheter. How is the meatus? Is it bronchitis or not? When the catheter was removed, why was it removed? Was it, is the passing well normally now or not? Maybe has a BPH component which has led to hematuria and something like that. You in your one of your diagnosis could also have been prostate cancer presenting with all of this. So upper tract changes causing hydronephrosis and pain, and things can be explained that way. So be very sure that any event which has happened, keep a follow-up.
Yes, sir. Yes.
Okay. So I think the history examinations sounds all right. So Jaideep, you want to add with start with investigation? What do you want to know?
Sir, I would like to get some blood investigations that should include the complete blood count, the kidney function tests, the coagulation profile of the patient, some urine analysis, urine microscopy, and a urine culture. Uh, uh, since the patient is a 60-year-old male, sir, I would also like to get a serum PSA, as we should have kept a diagnosis provisional of BPH or carcinoma prostate. Then after these and some radiological investigations, sir, first of all, I would like to get a ultrasound kidney, ureter, bladder, and prostate of the patient, sir.
Okay. So can you, would you, Surendra, you would like to start with ultrasound? You would like to send his blood investigation first,
Sir,
if given a choice?
start with blood investigation, sir. Complete blood count, kidney function test, and urine test, urine RM, routine microscopy, urine culture, and then ultrasounds.
Okay, fair. It's always a query in the exam what to proceed, whether to start with diagnosing first versus investigating. So it should be led based on the symptoms of the patient. Let's say you find him very severely pale and things like that, or very emaciated, then you might actually start with blood investigation so that you can tide over any emergency situations. Otherwise, in a reasonably good patient, you should start with first of all knowing what is happening. So I would say in this gentleman was a good PS, an ultrasound first investigation is okay to answer, because then you know what are, so your blood investigation can also be tailored based on your suspicion of the diagnosis. You getting me?
Yes, sir.
Yeah. So Dr. Uday and Mandal sir, you will add something.
Yeah, ultrasound can actually, if you see, you can tailor the investigation according to the ultrasonography report. If you're suspecting some upper tract disease, your sea bladder, you can get the cytology, all this, the investigation done, urine investigation especially.
Yeah.
And then you can
So
take a CT scan, whether which kind of CT scan would you like to get it. Then, if it is renal tumor or excessive bladder, so then you require a angiographic phase, and say bladder just upper tract disease, you require a CT uram, etc.
perfect. Mandal
In
sir.
in fact, if such a patient comes into your emergency, as a urology trainee, I think everywhere nowadays you have got access to an ultrasound. So, these are all simultaneous measures. You will send blood samples, you will take the patient for a screening ultrasound that you learn you can do yourself. So that will give you a fairly good idea how to proceed. Go ahead.
Okay.
Coming to the investigations,
Yeah.
the lab investigations were as follows. The CBC, the hemoglobin was 8.1, TLC was 5.7, platelet counts was 5 lakhs, hematocrit was 26, RFT, the urea was 56, creat was 1.1, sodium was slightly on the lower side 128, potassium was 4.5, serum calcium was 8.3, serum PSA was 2.9, HbA1c was 7.8. Actually, LFT was also done. AST 53, ALT 29, and ALP of 98. The LDH was 154. The urine routine, unfortunately, I have not mentioned it here, was
Normal.
grossly normal with RBCs present.
Okay.
There was RBCs present, sir.
Okay. Let's come to the ultrasound. Ultrasound.
Sir, sir. Yes, sir. Unfortunately, we don't have the image of the ultrasound. It was just written on the referral card that patient had a right-sided renal mass approximately 74 cross 51 mm in the mid-pole. Left kidney was normal and the urinary bladder was normal.
No comment on prostate.
No, sir. They were. It was only written on the referral card. That was only written by the. There was no official report present.
Okay. So Surendra, what do you want to do next?
Sir, I want to further investigate the patient with CT. It's a multiphasic CT protocol.
So when you say multiphasic, what do you mean by that?
It's a plain film, early arterial phase, parenchymal phase, and one of our possibilities is also a upper tract urothelial cancer. So we also need excretory film here.
Okay. Jaideep, you agree or you differ?
Sir, along with a multiphasic CT, I would also like to get a CT of the thorax meanwhile, and it should involve all the non-enhanced phase, arterial phase, and a nephrogenic phase, and a delayed phase to see whether there is any involvement of the PCS or any upper tract malignancy. However, we are sure from the ultrasound report that it appears to be a renal mass, sir.
I think the prescription here is very important, that when you say you want to get a CT, it should be a triphasic CT. Non-contrast may or may not be essential in the present times, but a triphasic CT, which should involve arterial arterial phase, the venous phase, and the excretory phase. Non-contrast, they actually can may or may not be essential unless you have a calcification and you want to delineate what type it is. Otherwise, the triphasic CT should suffice. Okay. So a CT was done, Rajath?
Yes, sir. Yes, sir. Yes, sir. Yes, sir.
So,
This is the image of the CT.
Rajat,
This is the representative image of the CT.
Dr. Uday wants to make a
Yes,
comment.
sir.
actually, so regarding he told that he should get the CT chest as well. Na? So what are the indications to get the
Yes,
CT?
sir. It is done, sir. It is done.
No. He's asking Jaideep,
Sorry, sir.
what are the indications for doing a CT chest?
Because he told that he will get the CT chest done outside the just seeing that sonography.
Sir, mass as described on sonography was a 7.5 cross 5.5 centimeter mass, sir. So it's T1, T2A or T1, T2A mass, sir. So in that case, I would, since it's a large renal mass, there's an indication of CT. We can skip CTs in a mass which is less than 4 centimeters. So T1A mass, if we are suspecting a CT thorax, can be skipped. However, for any masses more than 4 centimeters, CT thorax is recommended.
So it's only on depending on the size of the mass. Some other factors can also determine whether you get the CT chest or other or
Sir, other
MRI done or CT MRI, CT brain done.
Sir, symptoms with which a patient presents definitely gives an indication for what imaging we need. If there would have been any symptoms which I would have suggested a brain metastasis, such as increased IC, then we would have gotten a brain MRI, or a bone scan would have also been a possible investigation if the patient presented with any bony pain. Uh, on CT scan, features suggestive of high-grade disease, such as local invasion or invasion into the pelvic axial system, or lymphadenopathy over in the CT scan would have also given me pointers to get a a CT thorax along with for the patient.
Yeah, so the features actually suggest of high risk disease more than T1A actually, and the
Yes.
symptoms they determine whether you want to get some more investigation or not. So
Yes.
go ahead.
This is the image of the CT that has
No,
been
no,
displayed.
let them read. Surendra, can you read the CT image?
Sir, this is a large heterogeneous enhancing mass uh, arising from the right kidney pole. I cannot comment which pole it is arising from because we need some more films for commenting on the pole in which pole it is arising from. And it is a heterogeneous enhancing and irregularly bordered and showing some area of necrosis and some calcification also there. And there is
Okay,
no invasion or infiltration in the surrounding viscera.
hmm.
Uh, the regarding the vascular or venous thrombus, I can't comment on this image.
Why?
But I cannot.
It's
I need
always
some more
a good
films.
habit to mention in the city what type of city is it, contrast enhanced or not? What phase of the contrast enhancement is it?
Right.
So in that line, can you
Okay.
answer now?
Sir, sir, it is the contrast enhanced CT of the whole abdomen, sir. Sorry.
Right. No. But when you read the CT on this film, if you want to answer in with respect to phase of the CT, which phase do you think this is?
This is a nephrogenic phase.
So why do you see the aorta so white? You can see the aorta absolutely white, right? Do you think a nephrogenic phase would have this kind of thing? There's an arterial phase CT, right? You can see the aorta completely bright and white.
Yes, sir.
And what is the structure next to the aorta? In the second film image, what is that
IVC.
structure? What do you see inside the IVC? Do you think what you see in the IVC is sinister or not?
Yes, sir. It seems like I thrombus
Seems like
involving the
thrombus,
IVC.
huh?
Yes.
Okay, so one mistake which everyone does is reading the IVC in an arterial phase. If you do that, there will be some mixing of arterial contrast into the vein IVC, and you will have this kind of picture. So if you see this thing, then you must always see the venous phase to
Venous.
confirm. Yes, so never comment IVC thrombus on an arterial phase. That's the message you should take. And what you see on the first film, just besides the aorta, there's a black structure. What is that?
That might be a lymph node.
Absolutely. So these things should come in your description. So Dr. Jain, can you now describe the CT in proper perspective?
Yes, sir. This is a multiphasic CT of the abdomen showing a early arterial phase, sir. A cut through the bilateral kidneys and the lower part of the liver, sir. There is a mass involving the right kidney. Most cannot comment exactly on the pole. Appears to be a mid-polar mass, sir. With peripheral enhancement and central necrotic components. The size, I would like to see the size also, sir, but I can't really say the size. I would also like to see whether there are any other tumors in the kidney. Following that, in the left-sided image, sir, I'm seeing right now, there appears to be a mass just beside the aorta, sir, which is most likely a interaortocaval lymph node. There is the renal vein I cannot appreciate really in this cut. Then in the second image on the right-sided image, sir, the IVC, it appears to be IVC only, sir, but however, I cannot be really sure from single image. And there is a central either, as you sir said, it might be layering of the contrast, but more likely it appears to be there appears to be a thrombus inside the renal vein. The left kidney appears to be normal in the CT scan which is given, and the part of the liver which is there, I could not see any space occupying lesion in the liver, and the rest of the abdomen in these two images appear to be normal, sir. These are the information I could gather from the two images.
Yeah, Dr. Uday sir and Mandal sir, you want to add something?
I just like to add, all the students, when you try to read the CT scan, go systematically. See, first you try to get an idea what is the nature of the lesion you are seeing. Most of you concentrate on lesion. Second part is once you think this is malignant, then you'll try to see uh, the CT, whatever available, with the idea of staging. So because you didn't go systematically, that's why you did not comment about the IVC and all, whatever you were seeing here, relations. In third phase, after this, you should try to interpret the findings, which would help you in planning of your surgery. Of course, this is only a representative section they're showing it, but you will have an access to the whole CT scan series. Whole CT scan series. Yeah, Dr. Uday, please.
Yes, sir. So if you see in the CT scan, this is looking highly aggressive kind of renal tuber, infiltrative, all these things. And so would you get the MRI done in this patient, or you are happy with the CT scan only?
Sir, I would like to see all the images of the CT scan. If we can get a proper delineation of the thrombus on the CT scan, sir, and MRI won't be necessary. But if we are having any doubts about renal vein invasion or the involvement of IVC wall or it does not appear, the mass appears away from the IVC wall. However, renal vein involvement we have, if we need to see, or the proximal extent of the thrombus is not available on the CT scan, then MRI would need to be prescribed to see the proper extent, sir.
And sir, if large thrombus involving the IVC and we can't have idea about the cranial extension of the thrombus in CT, then we go for MRI, or because it is better sensitivity for the cranial extension of MRI.
So, Surendra, let's discuss what are the indications for doing an MRI in a presence of IVC thrombus. I think you brought up that point. So let us, one of you can answer that, and then we add on to it.
So one is to identify the cranial extension.
Okay.
of
Renal extent, why do you say you would not be able to see on CT?
It is better delineate the MRI better delineate about the cranial extension of thrombuses. So MRI would be better for that. And also, if there is invasion of thrombus, IBC wall invasion by the thrombus, in that case, MRI is also better.
So when would you know that there is a wall invasion by thrombus? How would you know?
Is there any criteria where you can make a diagnosis? This could be the wall invasion, then you can get the MRI. Just seeing is there a size criteria, something like that? IBC.
Jaideep, Surendra?
Sorry, sir.
I've
No.
given you the hint actually.
Yeah, Uday sir actually gave you a hint. So if you see that a lot of collaterals or arterialized collaterals around the IVC wall, of the IVC wall is Dr. Uday, I also don't know the exact size. If you can
The size
enlighten
more
us.
than 2 centimeters, the width
Size
of
more than 2
then,
centimeters. Yeah,
more-
so you see a lot of collateral arterialization of the thrombus, or you see a size of IVC more than 2 centimeters, or the wall of IVC is not clearly seen. There's some irregular margins. These are the areas where you suspect that there might be invasion of IVC, and MRI would have a better soft tissue delineation of wall invasion vis-a-vis presence of intraluminal thrombus. Otherwise, to the upper extent, I honestly don't feel that you need to have an MRI. You can supplement your CT finding with a color Doppler, and more often than not, you'll be able to know the upper extent of thrombus. So it's only when you're suspecting a thrombus being invading the wall of IVC, based on the 3 criteria we discussed, that is when we should order a MR venography. Okay.
Yes.
And Dr. Anil Mandhani sir pointed out, we should also, as Mandal sir mentioned, very rightly, the approach to reading a CT should be extremely systematic. Then you will not miss anything. So you first describe the lesion of interest, then describe its the vascularity, then describe the nearby or adjacent organs with respect to surgical difficulty. So remember, in that order, you will not miss even a single thing. And Rajath, you should have actually given more images so that they would have answered
Yes, sir, it
rightly.
is there, sir. Actually, we have more.
Show us then.
Yeah.
It is-
At least you should know the extent of the IVC thrombus. So what
Yes,
level?
sir. Yes, sir. The image is there, sir. Actually, we've done
Exactly.
there's an image that shows the extent of the IVC thrombus also. It is
Okay.
placed.
Yeah, just keep it
I
there.
was
We'll have the discussion now. Okay, thank you.
Yeah. So Jaideep and
I
Surendra.
didn't want to crowd the slide with multiple images. That's why.
So Jaideep, you want to start?
Yes, sir. So in the coronal images, sir, the first image on the left side is showing me the mass, which similarly, sir, as in the axial images, it appears to be a mass involving the mid pole. But however, on the right side, sir, we can see the cranial extent of the thrombus, which is going supradiaphragmatically, sir, according to which I could say, sir. There is arterialization of the thrombus as well, sir. There are prominent collaterals which are running into the thrombus, and it appears to be a tumor thrombus only, which has been arterialized. In these cuts also, the solid organ, there appears to be no metastatic lesions in the liver, and the vein wall, sir. In this case, I think I cannot really say whether the IVC wall is involved or not, but the renal vein definitely appears to be involved by the tumor, sir. So at least a T3, T4, T3B, T3C disease.
Surendra, anything else to add?
Yes, sir. It seems like a B3C disease.
Perfect. So you should not comment on wall invasion on this reconstructed image. Another point to remember,
Okay.
because the reconstructed image is a radiological reconstruction. And the wall may not be picked up completely in one reconstruction. So it's always better to have an axial cuts to identify the invasion part of it, and based on the suspicion, Dr. SK Palsar added that the fat planes around the IVC around the wall, if you see clearly, then is less likely to be invaded. So these are the things which do point out whether the invasion or not, and based on which you can do MRI. Reconstruction helps you to know the upper extent of the thrombus. So what do you want to add? Any other investigation to be added, Surendra, now?
Yes, in this case, we can go for MRI,
MR venogram. Okay. Anything else to add? Let's say this is the upper extent which we are seeing anyway.
and also to rule out the distant mets, we go for CT chest.
Okay. CT chest is already there, right? You can see the CT chest.
You can see the chest as well.
The entire chest is seen now. Anything else to add?
And to identify whether it is a tumor thrombus or blank thrombus, we can go for a PET CT.
Not really. PET CT in RCC, now that's another chapter. How many of you really feel that PET CT in RCC is a good investigation?
No role of PET, sir. FDG PET, at least no role of FDG PET in renal cell carcinoma at present.
Yeah,
So
it unnecessarily picks up things which are not necessary, and you are always confused whether the things which have been picked up
sir,
are essential or not. So PET has no role, at least at this point of time,
it's better
in the
to we
primary.
can get a echo of the heart, sir, to see whether
Yes.
there is an arterial
Yes.
thrombus. We can
So
get a
whenever you see a
transfusion.
thrombus reaching all the way up to cavoatrial junction, it's always better to get a 2D echo. That will tell us many more things apart only from the thrombus. It will also tell us, is there a pulmonary hypertension kind of thing developing because of the outlet obstruction. It will give you a lot of other parameters which will help you for surgical planning. So 2D echo is must. And transvisual echo, you do it during intra-op monitoring. So maybe not be an investigation a priori, but when you do surgery, then a transvisual echo has to be continuously monitored with. So, Dr. Uday, anything?
Yes, sir. Yes, sir. I do agree with you, sir.
Yeah. So, MR venography, was it done?
Yes, sir. MR venography was done. It showed no venous wall invasion. The rest of the
Venous
findings were
organ,
similar, sir.
fair enough.
I
So,
think
MR
Rajat has
venography
also-
is a Surendra, is it a investigation with contrast, MR contrast?
Yes, sir. Gadolinium we use in our venography.
Jaideep?
So not necessarily, sir. A T2 weighted image in MR venography, the blood will act as a contrast itself. So not necessary to give a contrast, but a gadolinium enhanced contrast can also be given. But generally in MR venography, if we just want to see the prospect, like the extension of the thrombus, there's not really necessary to give a contrast.
Absolutely. So, MR venography, you don't need a contrast for the thrombus per se, because the blood itself will look white in the black IVC on a T2 weighted image, Surendra.
Yes.
Only that when you want to reconfirm whether there's invasion or not, suppose there's a wall artifact at one area and you want to see whether it's invasion or not, then you add a contrast. If there's an enhancement of this thrombus, then you think, okay, yes, this is a thrombus which is actually infiltrating. So that is the second phase. But in a typical MR venography, you don't need any contrast. Okay.
Yes,
Okay,
sir.
so let's move ahead.
Dr. Rajat, yeah, we have 10 more minutes, 5 more minutes for discussion, and we'll have 5 minutes for the questions here.
Actually, 2D echo was also done, sir, for the patient. That showed a tumor, a mass in the right atrium, approximately 52 or 5 with left diastolic dysfunction and trivial AR. The rest of the findings were normal.
Okay. So quickly, planning. what would you do?
Sir, since there's a thrombus, I would like to plan for surgery, sir. And I would like to first of all, before planning for the planning of surgery will include taking a CTVS surgery opinion and possibility of intraoperative assistance from the most likely, sir, I will need intraoperative assistance, so I will plan for that. Then I would get a pre-anesthetic checkup done for the patient and make sure he's fit for surgery. And then I'll plan for surgery, sir. Looking at the extent of thrombus, since it is going into the right atrium, a thoracoabdominal approach most likely will be necessary, and it might also require cardiopulmonary bypass, sir, because
Why are you adding so
we
many mites and may and things like you
will, sir.
already have a thrombus? You will
Yes,
require all of it, right? Be
yes,
confident
sir.
about
Yes,
that. Why are you
sorry.
saying might be required, might be thoracoabdominal? He will
Yes,
require
I
approach
will.
of thoracoabdominal.
Yes, sorry.
Or is
No,
there
you
a
have to
doubt
get
that
it.
you?
Yeah, you have to get the
No,
surgery
sir.
done in the CBTS OT only. Okay.
Yes, you will not
Yes,
be
sir.
might nahi hoga na. It has to be, yes.
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 Anything else to add, Surendra? You want to add something here?
Yes,
Apart
sir.
from
First
what
we
Jaideep said?
optimize the patient because patient hemoglobin is also 8.1
Very
and
good.
it is also glycosylated 7.1. So we first to optimize the patient, and the patient is also having COPD. So we first to optimize the patient
Would you
and
do a coronary angiography? No? Yes? Any thoughts?
yes, a patient might require atrial cavotomy also. So
नहीं केवोटॉमी से एंजियोग्राफी का क्या संबंध है कोई संबंध नहीं है ना so when a patient is 60-year-old with a diabetes with he might be having an underlying coronary disease also anyway you're going to open the heart for and putting on bypass for sure so it's better to get a coronary angiography priori and suppose you find a vessel disease there you can tackle it simultaneously. Okay, so generally CTVS surgeons would advise a coronary angiography in almost all patients where they have to open the chest and put them on bypass. It is a good habit so that you cannot do reapproach the same area again and again. You know? So it's a good investigation to be done when with a level 4 thrombus. Okay.
Uh, Anybody would like to get a pre-surgery angioembolization? Because you have to,
Yes.
the thrombus is so much arterialized. So any thought of that? Dr. Jaideep?
Uh, uh, yes, sir. A preoperative thromboembolization will help decreasing the vascularity of the tumor and the IVC thrombus as well, sir. But there are a lot of collaterals, and the it might it is not really with that after a thromboembolization we are not sure that the vascularity will decrease. However, since it is so extensive disease, it is better to get a thromboembolization done prior to surgery, sir.
Would you like to do it or not is the question
Yeah.
Mandal sir is asking.
Suppose there is not much of time. Suppose this patient was medically unfit to undergo surgery. What option do you have?
Then, sir, we should give him thromboembolization, which will alleviate his symptoms, so that will help.
What? Sorry, come back again, Jaideep.
Sir, if the patient is unfit for surgery, we need to manage his symptoms. He has presented with hematuria. In that case, thromboembolization would have helped decreasing his symptoms to some extent.
Thromboembolization. What is
All
thromboembolization?
Mhm.
Thromboembolization. Just think or what does it mean?
Sorry, sir, arterial
You want to do
embolization.
embolization of the kidney,
Arteries.
okay.
Yes.
angioembolization.
Angioembolization.
Angioembolization of the kidney, huh? But not a very good approach because angioembolization, these tumors, they have vascularity from elsewhere. So may not,
Yes.
his symptoms may not go. But anything else in the present era? Surendra?
What are the options, regarding the Dr. Ravi?
Surname, what? Yeah.
What are the other options if the patient is unfit for surgery or very frail?
Move. Mhm.
Present era, nothing? No options?
No, there are options, sir. We can give immune checkpoint inhibitors, sir. Nivolumab can be given. Uh, this has shown in the neoadjuvant setting. So this has shown to help in patients who are not surgical candidates. But however, the survival benefit is not that much, but we can offer something to the patient. And VEGFR agents can also be given, sir, to see whether it has any effect on the tumor thrombus. And there are
Okay. I think fair enough. You must answer this that okay, renal biopsy and offering them one of the immune checkpoint inhibitor or TKI is a possibility in the present era. So that should be offered in a situation where you're not able to do surgery. Fair enough. I think we don't have time, Dr. Bora. Do we have
Yes,
to
sir. We can
continue?
just wrap up and we can
Yeah.
finish off this presentation.
Dr.
from the
Rajath,
and we
you
do
can
the
say
question
what
and
was
answer.
done to this patient. You must know.
Yeah.
Sir, surgery was done, sir. We did a surgery. We removed the thrombus. The surgery was done in the CTVS OT when we did right-sided nephrectomy with IVC thrombectomy, sir.
What was done first? The thrombectomy.
Histology.
Sir, it was clear cell RCC, sir.
No, Rishi sir asked thrombectomy first or nephrectomy first?
Sorry.
Chalo, he's not sure.
Okay, so we can take some questions from the chat box. There are some questions from the chat box. One was whether we should do a biopsy or give a TKI for 2 months to change the level of the thrombus. So anyone can take from the examiners. Biopsy.
So I think we answered that biopsy and TK only when you're cornered and the patient is not fit for surgery. Otherwise, for downstaging the tumor, it's not a recommended procedure because he will throw up a thrombus into pulmonary artery and we might lose him. So it's always better that whenever the patient is fit and fine, just go ahead and do the surgery after initial optimization. Biopsy with TK is only an option when you are cornered without any chance of doing anything.
And the other question was whole body PET CT instead of CT. Will there be what's your thoughts on getting a whole body PET CT rather than getting a CT chest and abdomen?
Dr. Uday?
Yeah, so nowadays the people are getting the PSA PET if they are suspecting some kind of mets or something like that, so that they can offer some other like lutetium therapy, all these things, but not routinely actually.
Yeah. I think as per guideline for exam purpose, they should stick to CT abdomen and chest. PSMA PET is an upcoming investigation because it bounds to VEGF receptors and RCs are known to be VEGF avid, and that's the reason why it is being explored. But till we have a clear guideline on that, we should stick to CT chest and abdomen and MRI as and when required.
Okay, sir. Thank you, sir. Final comments from Rishi, sir, and then we can wind up this session. And Dr. Rishi.
We can take final comments from rather Dr. Mandal.
Yes, sir. Okay, sir. Dr. Mandal, sir.
Okay, I think the students did in general well, but this is not the usual performance in the exam because the presentation has got through a lot of revisions and additions, maybe from seniors. But what is important is that right in the beginning you said the HbA1c levels are high, so there you should have said that the diabetes was detected and managed. So overall patient management is extremely important. Ultimately, the patient has come with a problem, so that has to be tackled in a usual way. And that is seen as your competence during your training, during the exam, that how much you have achieved that competence that you can manage a patient comfortably and in a competent way.
And there is a final question from the chat box. What should be done first, thrombectomy or nephrectomy? I think examiners can take that. Dr. Ravi can answer that.
So obviously you will have to do it in a CTVS suit, and when what we do, I can tell you, I'm not sure is it the same across the country, but what we do is we ask our CTVS surgeon to open the chest, take all the controls, and then we start mobilizing the kidney. And once you have done the mobilization of kidney thoroughly, if it's a left-sided tumor, we actually cut it off, and then come on to the right side and do the thrombectomy. So at all cost, remember that you don't want to do nephrectomy and end up with a situation where there's a massive PT on table and you rush up with the and with the mortality, morbidity and mortality. So the most important thing is to prevention of this migration of thrombus. So transesophageal echo all throughout the procedure, right from the beginning till the end, till the thrombus is removed, is a must, is an essentiality. So our anesthesiologist actually would put a probe inside the esophagus and continuously monitor it while we do it. So it's a simultaneous procedure, but what we do is we take controls of the chest of the major vessels first, so that in case there is any thrombus migration, within few minutes we can approach and remove it and save the problem.
Thank you, sir. With the lack of time, we'll be moving on to the next session, the interesting session. Thank you, the examiners.
Thank you.
Yeah, we'll be moving on to the next session. That is an interesting session that is part of the Journal Club, where Dr. Devesh from PGI Chandigarh will be presenting overall survival with adjuvant pembrolizumab in renal cell carcinoma, keynote 564. And we have two residents who will check on this Journal Club article and give their viewpoints, Dr. Nandan and Dr. Prashasya from SMS Jaipur. And we have IGU editors on the panels to see whether the students are able to judge the article based on its merits and demerits. And for that we have Dr. Rajeev Kumar, Dr. Apul Goyal, Dr. Alan Mandani, and Dr. Rajeev Yadav as a chairpersons. And I also request Navneet to increase the membership, because we have house full, more than 100 members. So people are waiting for the login. So over to Dr. Devesh, you can start presenting your slides, and over to Dr. Rajeev, Dr. Apul, and Dr. Anil and Dr. Rajeev to take over the session. Thank you.
Hi, good morning. Thank you. So let's begin with the presentation of the abstract of the paper. We'll do the strengths and weaknesses at the end.
Good morning, sir. Am I visible, audible, and is the presentation visible?
Yeah, just go into the presentation mode.
Yes,
Make
sir.
it full screen, Devesh.
Is the presentation now visible, sir?
Yeah, but we're getting it in a presenter mode. So we see
a full scale.
future slides. We need to change the presentation mode.
Just a second, sir. Yeah. Can I start, sir? Good morning, everyone. I'm Dr. Devesh Dhamor. I am a senior resident in the Department of Urology at PGI. The journal for today's discussion is the overall survival with the adjuvant pembrolizumab in renal cell carcinoma, the outcomes from the keynote 564 trial published in the New England Journal of Medicine on April 18th, 2024 by Dr. T.K. Chowri et al. This is the third and final interim analysis of the Keynote 564 trial, with the first interim analysis published in 2021, the second interim analysis published in 2022. Coming to the background, locally advanced renal cell carcinoma is defined as a renal cell cancer with adjacent organ invasion, venous involvement or a lymph node positive disease. Partial or radical nephrectomy is the standard of care for locally advanced renal cell carcinomas, with almost half of these patients developing recurrence in the follow-up period. Most often, these recurrences are that of distant metastasis. The survival associated with the renal cell carcinoma, as per the SEER 2016 and NCI 2016 database, pertain to localized RCC having a 90 to 97.4% 5-year survival, sharply dropping to 65 to 78% in locally advanced renal cell carcinoma subgroups, with metastatic renal cell carcinomas having a 5-year survival of 12 to 26.7%. Various risk factors for recurrence have been identified, all of which has also been consolidated in the Leibovitz stratification, including the tumor size, the tumor stage, grade, and nodal involvement of disease. Adjuvant therapy pertaining to management for renal cell carcinoma has been a challenging field with limited success. The traditional chemotherapy has been proven ineffective for management. VEGF targeted therapy has been tried for management of renal cell carcinoma, although with limited success. Sunitinib was approved in the United States by the FDA as per the S-TRACK trial. However, that too was contradicted by the much larger ASSURE trial. At present, most patients are either enrolled in clinical trials or they're kept on active surveillance. Pembrolizumab is a humanized IgG4 monoclonal antibody which binds to the PD-1 receptor on T cells and prevents tumor-mediated inhibition of these cells, leading to immune tolerance. About 10 to 30% of renal cell carcinomas express PD-L1 receptors, with almost 50% RCCs expressing PD-L2. Methods. The trial design was that of a prospective randomized controlled trial, phase 3. It was a multi-center placebo-controlled double-blind trial where both the participant and the primary investigator were blinded, enrolling patients between June 30th, 2017 to September 20th, 2019, with the key primary objective of assessing the disease-free survival, hypothesizing pembrolizumab being superior to placebo with respect to disease-free survival. The key secondary objective was to assess the overall survival, with other secondary objectives being to assess the safety and tolerability profile with pembrolizumab, impact of PD-L1 expression by the tumor on the response with pembrolizumab therapy, and the patient-related outcome measures associated with treatment. In the inclusion criteria were patients more than equal to 18 years of age who had biopsy-proven clear cell renal carcinoma, with surgery done with clearance of obvious disease within 12 weeks of randomization, either being the surgery being a partial or a radical nephrectomy, or a metastasectomy, either synchronous or metachronous. The patients included in the trial were those who had high risk of recurrence as per the Leibovitz classification, and they were stratified into the intermediate to high risk groups belonging to PT2 grade 4 node negative or a PT3 disease. High risk group being a PT4, any grade N0 disease or any node positive disease. Another category, the M1 with no evidence of disease group, was added to the evaluation. Those patients who had oligometastasis, non-osseous, non-brain metastasis, with the metastasectomy done either synchronously or metachronously with complete clearance of obvious disease. These patients had to be adjuvant therapy naive and belonged to ECOG status 0 or 1. Any patients who had other major surgery within 12 weeks of randomization or had other malignancy requiring active treatment or surveillance were excluded. Also, patients who had prior RT given for renal cell carcinoma, had brain, bone mets, or residual disease, were immunocompromised either post-organ transplantation, being retropositive, or on chronic hemodialysis, were excluded. Any patients who had any active infection, were pregnant or were planning pregnancy, both male or female, were excluded, or had received prior immunotherapy. The sample size was calculated as per the Poisson's mixture model. According to the published literature and study assumptions, the cure rate was considered to be 0.3. The median disease-free survival was assumed to be 45 months in the placebo group, and assuming a yearly dropout of 2% in disease-free survival and 1% in the overall survival group. A sample size of 950 provided 95% power to detect a hazard ratio of 0.67 for pembrolizumab, maintaining an alpha level of 5% two-sided. The randomization was done in a 1:1 manner using the IVRS and IWRS system. And patient randomization was stratified according to the presence or absence of metastatic disease. Within the M0 subgroup, patients were stratified using the ECOG status and whether the patient participant was a US based citizen or not. The treatment arms were two arms. The intervention arm consisting of pembrolizumab given 200 milligrams 3 weekly IV. The control arm was the placebo arm consisting of saline infusion given 3 weekly IV. Both were given for a total of 17 cycles 3 weekly for a total of 1 year. Patients were followed up as per using CT or MRI chest, abdomen, and pelvis 3 monthly for the first year. Thereafter, 4 monthly for year 2 to 4, 6 monthly for year 5 and beyond. Bone scan and MRI brain were only done if indicated as per the symptomatic profile on follow-up. Beyond 1 year of treatment, either in the placebo or the treatment group, participants and the physicians were unblinded to allow unrestricted choice of treatment. Statistical analysis. The disease-free survival and overall survival were assessed using the non-parametric Kaplan-Meier analysis, using the stratified log rank test for treatment difference and stratified Cox proportional hazard model for magnitude of difference in an intention to treat analysis. The safety profile was described as per the descriptive statistics. Meton-Nerman method was used to compare the adverse events only in the serious adverse events and grade 3 to 5 adverse events in a per protocol analysis method. Patient-related outcome measures were measured using the constrained longitudinal data analysis method for a mean change over time, using a more stratified Meton-Nerman method for intergroup comparisons. Here is the consort diagram of the Keynote 564 trial. 1,406 patients were assessed for eligibility. 412 patients were excluded. 156 based on the presence of baseline disease. 125 patients not meeting other eligibility criteria, and 66 not meeting protocol defined criteria. 65 patients withdrew from screening. 994 patients were enrolled and randomly assigned, 496 into the pembrolizumab group and 498 into the placebo group, of which 8 patients in pembrolizumab group and 4 patients in the placebo group did not undergo treatment, assigned treatment. In the end, 488 patients in the pembrolizumab group and 496 patients in the placebo group received such treatment. 190 patients in the pembrolizumab group and 130 patients in the placebo group discontinued their assigned treatment during the first year. The various causes have been listed as above. 298 patients in the pembrolizumab group and 366 patients in the placebo group completed the intended treatment. The results, these are the baseline demographic characteristics of the study population. The study population was similar in the pembrolizumab and placebo groups in terms of most characteristic variables. One point to note is that most of the study population consisted of participants having undergone a radical nephrectomy. Most patients belong to the M0 intermediate to high risk groups, contributing to 85, almost 85 to 87% of the study population. Most patients did not have any sarcomatoid features on histology. Most patients belong to a pathological stage. I'm sorry.
Your slides are gone.
This
Reshare.
host, it's showing me host has disabled participant screen sharing. Is the presentation visible again, sir?
Yeah.
Yes.
Almost 90%, 88 to 90% patients belong to the stage T3 and node negative disease, all being contributing 94% of the study sample. Median follow-up of 57.2 months was taken with a median treatment duration of 11.1 months in both arms, with a median 17 doses being administered. Here is the non-parametric Kaplan-Meier analysis and the hazard ratios pertaining to the disease-free survival. In the Kaplan-Meier analysis, we can see there is early separation even before 5 months of pembrolizumab therapy, showing an improved disease-free survival with pembrolizumab. And at the end of almost 60 months of follow-up, 174 patients in the pembrolizumab group and 224 patients in the placebo group had disease recurrence or recurrence-related events with a hazard ratio of 0.72. The significance of improvement in disease-free survival was consistent as per the age high PD-L1 core positivity in the biopsy sample, M0 disease, M0 intermediate to high risk category, and absence of sarcomatoid features with pembrolizumab therapy. An overall of 161 patients had documented recurrences in the pembrolizumab group, counting of to 32.5% of the study population, and 210 patients in the placebo group, accounting to 42.2% of the study sample. Most of the recurrences were distant, 143 in the pembrolizumab group and 179 in the distant in the placebo group. 132 patients and 172 patients in the pembrolizumab and placebo groups received subsequent therapy after completion of 1 year of both the arms. Here is the overall survival Kaplan-Meier curves and the hazard ratios of overall survival comparing pembrolizumab to placebo group, showing the Kaplan-Meier analysis shows early separation at about 10 to 15 months of follow-up, which was consistently increasing with follow-up, supporting use of pembrolizumab, with 55 deaths in the pembrolizumab group and 86 deaths in the placebo group, with a hazard ratio of 0.62. There was a significant improvement in overall survival on subgroup analysis with a younger age of less than 65 years, male gender, higher PD-L1 core positivity, M0 stage, and M0 intermediate to high risk disease category. The benefit in disease free survival in the M1 no evidence of disease metastatic staging and M0 high risk category does not seem to confer an overall survival benefit on this analysis. The benefit with the pembrolizumab therapy pertaining to overall survival was present in the absence of sarcomatoid features. The overall survival with pembrolizumab was found to be 96, 94, and 91% at 24, 36, and 48 months of follow-up, as against placebo having 94, 89, and 86% overall survival at 24, 36, and 48 months of follow-up. The adverse events were reported as per the CTCAE grading. The adverse events of any grade, adverse events grade 3 to 5, and serious adverse events were significantly high in the pembrolizumab group compared to the placebo group, which resulted in almost 17.6% patients discontinuing pembrolizumab therapy. However, there was no death related to any adverse events. Here is the CLDA charts for the patient-related outcome measures. The left chart showing the changes in EORTC scores over the follow-up period, and the right chart showing the trend of FKSI score over the follow-up period, both of which show no significant deterioration in the follow-up period. Also, there was no significant difference in the scores between the pembrolizumab and placebo groups. Discussion. Disease-free survival benefit was consistent since the first interim analysis with pembrolizumab therapy with a hazard ratio of 0.72. Pembrolizumab significantly reduced the risk of death by 38% compared to placebo group with a hazard ratio of 0.62. On subgroup analysis, overall survival benefits were observed across ECOG performance status 0, absence of sarcomatoid features, M0 disease, or belonging to an intermediate to high risk group. Wide confidence intervals in some subgroups could be due to the small representative sample sizes in that group. Few patients in the pembrolizumab group had recurrence compared to placebo, with concomitant decreased need for subsequent therapy. The sites of recurrence did not vary in the two treatment groups. In terms of safety, there was a higher incidence of adverse events, grade 3, 4 adverse events, and serious adverse events. However, there was no treatment-related deaths, with 17.6% patients discontinuing pembrolizumab due to adverse events. Prior to this trial, the only drug which was approved, that was sunitinib, had much higher rates of discontinuation due to adverse events as per the extract trial, which was 28.6%. Despite the adverse events, the patient-related outcome measures showed no significant difference. Strengths of the trial, Keynote 564 trial is the only trial at present showing improvement in disease-free survival and overall survival with immunotherapy for renal cell carcinoma with high risk of recurrence, with other trials such as the IM Motion 010, Prosper trial, and Checkmate 914 trial showing no survival benefits. The differences in drug properties, trial designs, and populations might explain its variability. None of the trials which have assessed tyrosine kinase inhibitors for treatment have had any significant results except for the STRAC trial, which has its own limitations. The Keynote 564 trial had a large sample size, even more than the planned sample size of 950. It was a randomized double-blind study and a multi-center study. The limitations, most of the subgroup analysis data is hypothesis generating, being underpowered to analyze the same. Majority of the treatment population consisted of patients belonging to the T3N0 disease, with little assessment of the impact of pembrolizumab on higher stages of non-metastatic RCC. Also, there was no analysis done to determine the optimum duration of pembrolizumab therapy, and the therapy schedule was followed as is done for the treatment of melanoma. Keynote 564 trial establishes pembrolizumab as a new standard for high-risk clear cell carcinoma post-nephrectomy. Balancing the efficacy benefits with potential adverse events is critical for treatment decisions.
All right, good. Well done. That's a very good summary. You've done a good job putting it all together. Now, do we have anybody else among the residents who are going to talk about it, or
Yes,
is
sir.
it
Two
only
residents are assigned, Dr. Nandan and Dr. Prashashya. So Dr. Nandan is a resident at RML Lucknow. Dr. Prashashya is a resident at SMS Jaipur. And they
Yes,
can...
good morning, sir. Dr. Nandan from RML Lucknow, sir.
Okay?
Sir,
So are you going to be speaking on your own, or are you going to be answering questions? What is the format proposed?
Sir, they can give their thoughts about the journal articles, and then they can be asked questions how they came.
All right. All right. So let's first hear what do you have to say about the paper.
Sir, it is a well presented paper, but the things are only limitation is as far as I can see is like the subgroup analysis, in which, sir, I can see that the majority of the patients, almost 85%, they belong to intermediate to high risk patients, and less patients are there in the subgroups like M0 high risk patient or M1 NED patients. So in those patients, we cannot assess the role of pembrolizumab as such, like how was the subgroup analysis in those groups for overall survival. Overall survival per se, according to the Kaplan-Meier curve, is good. But in the subgroup analysis, there is one limitation, sir. Like very less patients are there. Also, the patient with sarcomatoid features, they're very less in number. So we can't say that what is the exact role of pembrolizumab in such patients, sir.
All right, but was that their objective? Were those patients their primary objective, or was the study primarily targeting locally advanced disease, which would include the M0 high risk, but the bulk of the clinical patients would probably be the ones that they've included? That was their whole objective. So what you're saying is right. You cannot extrapolate the results to the two groups you talked about, which is M0 high risk and M1 NED. That was not their target at all, actually. Therefore, in that sense, I'm not sure that's considered a limitation. The limitation that you have stated and has been, it's actually given in the paper itself, is that you can't rely on subgroup analysis to make a decision. That is true of every paper. In no paper is a subgroup analysis going to be the primary analysis. That's always hypothesis generating. What this means is, we looked at this subgroup. It seems to suggest that there may be benefit, but we are not adequately powered. Therefore, please do another trial on this specific subgroup. That is the meaning of hypothesis generating. It's giving you a research question for future trials. And that's what all subgroup analyses are expected to do. So that's not a limitation of this particular paper. This paper wasn't, I mean, whenever you judge a paper, you don't judge it for how good is the subgroup analysis. You judge it for how good is the primary analysis. The subgroup analysis is always just hypothesis generating. Let's do another study to look at this. So I won't call that really a serious limitation of the paper. Okay,
Yes.
anything else? Prashasya?
Yes, sir, it seems to, sir, can you hear me?
Yeah, we can hear you. Go ahead.
Sir, it seems to be a well randomized paper, and um, personally, I have not many comments to make regarding its limitation. It does raises some questions to do further studies, and um, that's all I can say, sir.
All right, good. So, go ahead. Sorry.
Yeah, Rajiv, hi. May
Hi,
I?
Anil, go ahead. Yeah.
Okay, so Nandan, you said it does have survival advantage if you give pembrolizumab to your patient. So will you give PEM to your patient tomorrow if you come across such situation?
Sir, talking about our situation or our country, although seeing the cost benefit analysis also keeping in mind, but yes, I will do recommend sir pembrolizumab in those patients like I am suspecting according to Lebovich scoring if they are going into a risk for higher recurrence rate if they are
So
high risk.
how much is the difference in survival?
Sir, per se, this according to this keynote study, sir, there is a statistical difference, not much, but sir, there is a statistical difference.
So you read the paper. So I mean, they say the relative risk reduction is around 32%. Absolute risk reduction is 5%.
5%.
So what is the NNT number needed to treat? Is around 20, 100 by absolute risk reduction. So you need to treat 20 patients to get advantage in one. Okay, so in 19, you are giving unnecessary medicine, unfortunately, which we cannot predict. So it does, I mean, this drug seems to be promising. But if you ask me, literally, as of now, in this setting, I mean, when you don't see a disease like TKI, we don't give TKI when you don't have a disease. But this may have some advantage, but still, I mean, data is not robust to recommend. I know medical oncologists are giving left, right, and center, but still, I mean, NNT is quite high, and it does have toxicity. Another thing which I read in the paper, the recurrence. The recurrence at 57 months was not much different. I mean, 80 versus 81%, if I'm not wrong. So in longer term, recurrence is the same, and the overall survival difference is marginal. So I would not call it a robust data to suggest that we should be using it in adjuvant setting. Do you understand the hazard ratio of
Yes, sir.
0.67 means what?
So hazard ratio is basically it is calculated by like experimental group about divided by the control group. It means if it is less than 1, it means if you are giving some drug,
No,
then
no,
it is causing,
0.67 means what?
like the drug is causing benefit.
How much benefit? What do you tell to the patient?
So again, it will be like 0.6 means like out of 10, it will be benefiting 6 patients somewhere.
No. Any other resident? Because I find that this is the most wrongly construed data in journals. Most of us do not understand hazard ratio, and we misconstrue it when it comes to discussing with the patient. Like more often than not, what we see that if hazard ratio is 0.6, that means 40% risk reduction. So like, so because it is calculated on Kaplan-Meier. Okay, so when you come to survival, you may say there is 40% improvement in survival with pembrolizumab, 0.6 HR, which is not so. And anyone can explain this.
Dr. Devesh, can you answer that?
Yes, sir. Sir, hazard ratio of 0.67 would approximately mean that in terms of disease-free survival, about 33% reduction when comparing the experimental arm to the control arm, placebo
So
arm.
if placebo is surviving for 5 years, and if you give PEM, so he'll survive for
33% more compared.
So yeah, that's the problem. Actually, it's not calculated in quantum way. It is not so. So that's the reason, most of the medical rep will come and tell you that this is a survival advantage. This is just the rate of meeting that endpoint. I mean, both the groups, both the patients will die. If you're giving drug, the rate of death would be slower. You should never quantify in terms of months or years. The rate of death would be slower, and that arm would still be subjected to risk factors leading to death. Yeah, it's not that easy. Anyway, please carry on.
Okay. Yeah, thanks, Anil. Apul, do you want to say something?
Okay, well presented, first of all. And in the preamble, you were sort of telling that it was locally advanced. So this is not true, actually. They included T2 patients. It is basically high risk, intermediate high risk group that they are talking about. So just a clarification, it is
Yes, sir.
not locally advanced. So otherwise, a well-presented paper, and actually these papers are by multiple authors. They are professionals. They are too good actually for comments and to find limitations. And otherwise, also the limitations have already been discussed.
Yeah, one more point I would like to add. This was sponsored by Merck, which is MSD in India. So all pharmaceutical companies sponsored trial, you should see the article with an eye of suspicion.
Right. Thank you both. You've summarized a lot of things well. I'm just going to put a few things in perspective. Anil, you're absolutely right. It's a sponsored trial, but then the fact is all such trials will always be sponsored. These are exploratory trials. They cost a lot of money, and these are drugs which are proprietary to the manufacturer. So nobody else can do the trial, and no government will fund a trial for this much money for these patients. So unfortunately, it's a fact of life that all such trials will be pharma funded. But then Anil's point remains moot that you do need to look at them carefully before you accept it. Whenever you do a journal club, there are two aspects to a journal club. The first aspect is to understand the science that is being presented, and the second aspect is to understand the methodology that is being described. And although the paper is in the New England Journal of Medicine, that doesn't mean it's perfect. There are still problems with the manuscript itself, and then of course there are problems with the interpretation. Let's first begin with the title, and I think that's the most stark example of where I think there is a problem with this paper. What does the title say, Devesh?
The title states the overall survival with adjuvant therapy in renal cell carcinoma.
All right, let's stop. If you were to read only this title, what would you assume? Is this a review article? Is this a randomized controlled trial? Is this a case series? What does it tell you?
Sir, I would say that it is some author assessing all the published literature and presenting a review on the same,
The
or their
title, to
own
my
expert
mind, is
opinion.
poor. What you're saying is right. I agree with you. The title is poor. The title doesn't tell me what do I expect to find in this paper. If I was only reading the titles, which is what typically happens when you do an initial search on PubMed, I would not know whether this is a review, a systematic review, a meta-analysis, an original article. What is it? Therefore, the first thing is that the title should have the PCOT in it. Now, although it's a third analysis, the title will become large. You would say results of a third analysis of the randomized Keynote 564 trial, which looking at just the title would tell me where it stands in terms of the hierarchy of evidence and how it relates to other previously published articles. So the title itself is, to my mind, not the best title. And going into the NEJM, I would have expected a much better title than what's come in. Now let's go on to, there are other smaller points in the presentation. I'm not going to get into that because they're nitpicky to a large extent, so we won't go into them. Let's now go into the critical analysis of a paper like this. When you look at a drug trial and you see overall survival, what are you trying to assess? And Anil covered this point beautifully by talking about number needed to treat. All of us in the urology community, to a large extent, believe that when you have metastatic cancer, additional therapy helps. That is an established fact today, that whether you're using TKIs in the past or you're using IO TKIs today, which are now first-line therapy, or IO, they are now established through a large number of trials that they help improve survival in the metastatic setting. So all of us accept that. What is new in this trial? This trial is now trying to suggest that give it to everyone, even before metastasis has occurred. Give it to almost everyone, except for the T1 disease and the T2 low risk disease. Everybody else should get it. Therefore, the immediate question that should come to your mind is, should I give it to everyone? Or should I give it to only those who've developed metastases? Is there really a difference in giving it to patients who've already got metastatic disease versus giving it to everyone? So your comparator ideally should be looking at data that if I had given these drugs only to those who developed metastases, would survival have been any different? And why does that question rise? Now you go back to analyzing the data on this paper. Look at the control arm. In the control arm, 40% of patients only developed recurrence at 5 years. Therefore, 60% of patients, even if they got nothing, would not have had any disease even at 5 years. And most of us accept a 5-year disease-free survival as a surrogate for overall survival. It's not an absolute marker, but it's a likelihood. What this means is 60% of patients, even if you've done nothing, would not have needed therapy. That's part one. Therefore, you need to sub-select a group of patients who do need this therapy to avoid adverse effects. And the adverse effects are important because 20% of patients dropped out after receiving just 1 to 5 or to 8 doses. Therefore, the drug adverse effects are significant. If they hadn't dropped out, you possibly could have seen more deaths related to pembro. Therefore, the argument that pembro did not cause any deaths needs to be given known with the knowledge that many of them actually dropped out and didn't even take the full pembro. So if they'd got the full pembro, it's possible that the serious adverse effects due to pembro would have been higher, which is what all of us clinicians find. Why are we scared? It's not just money. Many of our patients are now covered by insurance. Yet we don't want to give it. It's because of adverse effects. And particularly with IOs, the adverse effects are no longer dose related. When you used to give TKIs, you'd get hand-foot syndrome, you'd get hypertension. You stop the drug, it would go away. When you look at IOs, these are autoimmune disorders that happen. IOs predispose to conditions which are very similar to autoimmune. So you get mucositis, pneumonitis, gastritis, colitis, and these are not dose dependent. Once they've started, even if you take pembro off, they will continue. And that's why most of us are scared of giving IOs. They work beautifully, but we want to find the right patient who is likely to benefit. And that is why if you were to decrease the numbers who dropped out and decrease the numbers who never progressed even in the placebo arm, the actual number who's likely to benefit, and again I come back to what Anil said, NNT is likely to be small. When you look at trials like these, that's one important thing you need to look at. What if I hadn't given the drug? How many would not have got the disease? The second very important thing. Okay, the second very important thing you need to look at is the difference between the American population and the Chinese population. Let's not call it Chinese, the non-American, because they were Europeans also. If you look at the forest plot among the American subjects, although they were only 25%, there was no benefit. If you look at the non-Americans, there was a very significant benefit. Now, of course, this is a subgroup analysis, so it comes with that limitation that you're looking at a smaller group. But why does this happen? It should raise a question in your mind. I'll tell you why this happens. In America, or in good, well-funded countries, if the patient progresses after a certain treatment, now this treatment is only for 1 year, whether it's placebo or therapy, it's only for 1 year. Let's assume the patient didn't progress in that 1 year, but after about 3 or 4 years, he progressed. Because they have good insurance cover, they would then get pembro, exit, pembro, nivo, IP, whatever. And their survival would be improved because we know those drugs improve survival in metastatic disease. On the other hand, people in other countries, such as third world countries where patients were recruited, if they progressed after the initial trial covered phase, trial only covered them for drugs for 1 year. If they progressed after 1 year, they would not have access to additional therapy and they would die. Therefore, the gap between drug and no drug, where does this make a difference? It makes a difference in the placebo group. In the therapy group, let's call it Chinese and America, just to make life easier. Although it's not necessarily China and America, let's just say China and America. In both China and America, the drug group got drug, so they benefited. The placebo group should theoretically have got pembro when they progressed. In America, they got it. In China, they did not get it. Therefore, in America, there is no difference between whether you got pembro upfront or you got pembro when you progressed. There is no survival benefit between those two arms. China, the drug guys who got pembro upfront did very good. Guys who got placebo upfront and should have got pembro when they progressed couldn't afford the pembro, never got the pembro. Therefore, the gap between drug and control is higher, so significantly different. So this is a common problem with multicentric trials where there is no long-term therapy, and the China group makes the entire group look nicer because the gap between the drug and the control group is now significant. So these are analyses which you need to think about. And of course, the other fact that there are 4 other trials which have found no benefit. We all know that studies are like this. It happens this way, but you need to analyze them in this manner. Rishi is telling me to move on. I understand, Rishi. So we're going to close this for now. If any of you have any questions, I know it's not easy to understand. These are things which take a little while to understand, but brilliantly presented. I thought you summarized it very, very well. It was a very good presentation. And I can understand you're getting scared कि NEJM के article को कैसे criticize करें, but even the NEJM article and its interpretation can at times be analyzed. I'll close here. Any questions? I'll happy to answer, but I'll close. Back to you, Rishi.
Yeah, thank you, sir. Thank you for the in-depth analysis of the things, and probably we'll go back again to see the video and see again the in-depth analysis given by you. But as lack of time, and we can have the questions on the chat box and answers there. We can move on to the next session. That is a very important session on the surgical craft video presentation. It's we take only one simple surgery on one step technique, and we elaborate for the residents how to go about from basics to the advanced. And to give that talk is Dr. Sudheer K Devana. Is additional professor of urology at PGI Chandigarh, and he has a core area of interest in urolithiasis and spreading the knowledge of technique of PCNL along with our chairpersons who are spreading the knowledge of doing PCNLs, Dr. Madhu Agarwal, Dr. Pal sir, and also we have chairpersons Dr. Tanuj, Dr. Vimal, and Dr. Ashok. So we will have a 20-minute video here, and after that 10 minutes of the discussion with the stalwarts of PCNL. So we can start with Dr. Sudheer. Dr. Sudheer, please. Dr. Sudheer, you can unmute yourself and we can start the presentation. Unmute yourself. Please make Dr. Sudheer the co-host so that he can unmute himself. Dr. Sudheer. Yeah.
Am I audible now?
Yeah, you are audible. Share your screen.
Good afternoon, everyone. Respected chairpersons, dear delegates and residents. At the outset, I want to thank Dr. Girdhar, Bora, and Dr. Rishi Nair for giving me an opportunity to present a talk on the technique of standard PCNL, which is a very important topic for residents because the basics which you get while performing this procedure are very important for your subsequent endourological career. So I start with since this talk is for specifically focused on for residents, I just want to start a few points about related to the anatomy of the kidney, which is the applied anatomy related to the PCNL, and then analyzing the preoperative imaging followed by the puncture techniques and then the procedure, complete procedure of the PCNL. So let's start with the applied anatomy. I think every one of us know about the anatomy of the kidney, where we know that the site of entry to the papilla is the area where you have the least chance of injury to the vessels. And you can see in this image where you see the majority of the vessels are actually focused on to the infundibulum of the pelvic calyceal system, and the papilla of the calyces is the area where you have the free area which is without any vessels. So it's obvious that going through a papilla is the one which prevents a major vascular injury. And so you should the same thing is shown here that you see through the cup of the papilla, if you enter, the chance of injury to vessels is less. So pharyngeal puncture should be the goal. And a bit of calyceal position in related to the poles of the kidney also you should understand that the superior calyceal system is drained by a single infundibulum with a compound calyceal system, which is seen almost always. Whereas if you go to the middle calyceal, this is the most important calyceal group where you have always a fixed pair of anterior and posterior calyceal orientation, which is ideal for puncturing. And the inferior calyceal system also you have long infundibulum, and sometimes you have compound calyces there. And the most important thing is the orientation of the calyx into the anterior and the posterior. We all know that the Brodels type systems where the posterior calyx is angulated at 20 degrees to the frontal plane, whereas in Hudson's type, the posterior calyx is angulated at 70 degrees to the frontal plane. Now, this is one of my patients only where you can see clearly the posterior calyces which are seen more medially, whereas the anterior calyces are generally seen laterally. So coming to the other pictures by the Sampo classification, you see always you have to look for this posterior calyx. Many a times this calyx is hidden unless and until you inject air, you don't see this calyx. So here also you can see a mid posterior calyx and this is a mid anterior calyx. And sometimes you have perpendicular minor calyces which are actually oriented against the infundibulum. Here in the superior calyx, as many of the people say that the superior calyx has a medial and lateral orientation, but sometimes you can have a posterior calyx there also, which is pointed directly to the 0 degree position. So in this image also you can see the posterior part of the inferior calyx, there is a rounded calyx here, which is where the air is seen. So hence, why should we consider the posterior calyx a very important calyx for puncture rather than an anterior calyx? Because the posterior calyx, if you see, it is actually very close to the avascular plane, that is the Brodels avascular plane. Like if you see the posterior segmental artery supplies this part of the kidney, whereas anteriorly the kidney is supplied predominantly by multiple branches. So there is a plane in the frontal plane which is actually slightly posterior, which comes close to the posterior calyx. And it is the shortest and the straightest path to the kidney. Suppose in this example, you can see this is a stone lying in the pelvis, the same image which I have shown before. On intraoperative RGP, the posterior calyces are not seen initially. But if you see in the imaging, there are two posterior calyces lying here. So what we did, we inject air. So when we inject air, you can faintly see a rounded area here, which is corresponding to the same calyx in the preoperative imaging. So in that calyx, that's the calyx is the posterior calyx. And once you puncture that calyx in 30 degree by bullseye technique, you can see the guide wire going freely into the system. And you can confirm the same thing also on endoscopy, that the infundibulum of the calyx is seen in front of you, would suggest that you have entered through the papilla. So it offers straight entry to the pelviureteric junction, the mid posterior calyx. And of course, the anterior calyces are seen in a dependent position. So ergonomically, this posterior calyx offers a better access to the kidney. And also another important thing, like in this image, if you see here, this is the anterior calyx. You can see here the anterior calyx is shown pointed by the arrow here, whereas the posterior calyx is here. So obviously, when you try to puncture an anterior calyx, you are going more closer to the colon. Like in the lower pole, more so in the lower pole, you see the colon is very close. So that's it. So the posterior calyx actually makes your have the punctures more medial, and there are less chance of injury to the colon. The same is shown in this image also. You can see the anterior calyx here, the posterior calyx, and if you see the shadow of the colon here, it is actually more close to an anterior calyx when you compare it with a posterior calyx. Now, analyzing an IVP always it's very important before you plan a PCNL. So if you see in this IVP image, when you see the image, you see that faintly looking calyx which is seen in the initial part of the IVP here, whereas in the other film, just a second. In the other film, you see the calyx is now seen a little bit better because the patient is lying in supine position when the IVP is done. The posterior calyces are seen more brighter. Now coming to the same image, if you see in the subsequent images in RGP, subsequent images of the IVP at 30 minutes, you see two more calyces are seen now clearly. They are medial. So the medially located calyx are the posterior calyx, whereas the laterally located calyx are the anterior calyx. You can see it here. But how do you know that this calyx is a posterior calyx or an anterior calyx? When the patient is made into prone, if you compare this previous IVP image with this image, this is supine image, this is prone image, you can clearly see that the posteriorly located calyx, they disappear in prone position because the contrast is now in a non-dependent position. The contrast drops down into the system and those calyx will disappear. So that way you can confirm that these calyx, which is seen better in a supine film, whereas in a prone position that calyx is not seen. That's why intraoperatively when you do RGP, these calyxes are not generally seen unless and until, if the system is small, you can inject more contrast to see them. Otherwise, air has to be injected to see these calyces. Now, coming to the basic definition of standard PCNL, yes, any puncture which is more than 22 French diameter is considered standard, whereas the nomenclature of PCNL is varied. Like you can see the mini PCNL is less than or equal to 22 French, and you have other types of PCNL where ultra mini, super mini, and micro PCNLs are there. So for the topic of discussion is on standard, so I am skipping the rest. Now the positions, yes, prone position, lateral position, supine position, lot of positions are described for performing PCNL. But for the sake of residents understanding, prone position, which is the standard technique which everybody should know, so that's why I'm presenting that. So initial step obviously is the patient placing the patient in lithotomy position, and first step is the placing the ureter catheter. Of course, this is one case which we operated recently. There was a diverticulum which was a surprise intraoperatively. So the initial step is placing the ureter catheter. The most important step is we generally fix the ureter catheter with the Foley's, because when you turn the patient to prone position, sometimes this ureter catheter gets dislodged. So that's why it is a good habit we do like this. Always we drape it with sterile cotton and like that. And then you position the patient in prone position. The most important thing is the padding the areas where there are the pressure points, like keeping a cotton at the arms, and also another important step is raising the kidney bridge will help while doing prone PCNL, because it increases the distance between the iliac crest and the 12th rib. So that opens a space for passing the needle. And of course, the positioning and draping and should be like this. And after that, you drape the patient. And the most important thing is the positioning the C-arm properly. To do the procedure, you have to raise the table according to the movements of the C-arm, so that it moves in 0 to 30 degree well. Then after that, we come to the puncture technique. Now, if you go to the puncture technique, the standard fluoroscopic guided punctures are the bullseye technique and the triangulation technique. Of course, ultrasound guided puncture can be done. And the other technique which was been described is the endoscopic guided technique. Now, the golden rule which everyone should remember is that the posterior calyces always move medially when the C-arm is rotated from 0 degree position to 30 degree position. This is the most important golden rule which everyone should remember, because with this only we identify whether the calyx is posterior or anterior. Now, coming to the identification of posterior calyx in this given case, like in this image, you can see a pelvic stone and two inferior calyceal stone. And just for the understanding, I'm showing here. See, initially contrast is injected. You see the anterior calyces first because the patient is lying prone. Now you see when air is injected, you see faint rounded areas here and another one here also. So this is a posterior inferior calyx. This is a posterior middle calyx. There is another calyx at the superior also. So this calyx is moved medially. When I moved the C-arm, it moved medially to the spine. So that is the one which identifies as a posterior calyx, and that is punctured. Now, coming to the bullseye technique, this is the briefly mentioning how the bullseye technique to be done. First, the most important thing is the puncture needle, which should lie parallel to the axis of the C-arm. Then, with the C-arm in 30 degree, you align the puncture needle along the axis of the desired calyx. Then you pass the needle in that position for few centimeters. Now, to look for the depth of the needle, whether it has reached the calyx or not, you rotate the C-arm to 0 degree and you assess the depth in that position. If the needle is still away from the desired calyx, then again rotate the C-arm back to 30 degree and align the needle in line with the calyx and then pass it further. Now, the same thing I'm showing through diagram to the photographs. You can see first and important step of bullseye technique is the C-arm should lie and the needle should lie in the same axis. So they are parallel to each other. Now, the other position is keeping the needle in line with the axis of the C-arm by rotating the C-arm to 30 degree. and you align the needle, the CM and the calyx in one line. That is the most important step of performing bullseye technique. Then for seeing the depth of the needle, you assess you rotate the CM back to 0 and see the depth, whether it has reached the calyx or not. Now let us go with an example here. Now you can see in this technique I am showing, because this is the most important thing, I am going a little bit slow here. That's a pelvic stone. We are doing RGP. You can see in the IVP also there is a calyx here, which is a mid-posterior calyx. Now if you see here, the same calyx is seen here with the contrast. Now see, when I rotate the CM, what I said, that the calyx moves medially when you rotate the CM from 0 to 30 degree. So these are the anterior calyx which I am showing. Now let's see what happens when we rotate the CM. So the same calyx which you are seeing here is seen here. Now see, when I did 0 to 30, the calyx actually moved medially, this one. Now again, focus on that. You see that this is the calyx which you are talking about, the mid-posterior calyx. See, posterior calyx always moves medially. See, it is coming medially. So this suggests that the calyx is actually the posterior calyx. These are all the anterior calyxes which you are seeing here because they are lateral. Now you see, I align the needle in 30 degree with the calyx. That is the eye of the needle technique or the bullseye technique. You see the CM is in 30. I am aligning the needle with an artery there. That's the needle. Now once the needle is aligned with the calyx, you push the needle inside. So after this, the CM is now moved to 30. I am passing the needle inside. Now you see I rotated the CM to 0 now. Now once you rotate the CM, still the needle is not in the calyx. So again I rotated the CM back to 30. Now I am passing the needle further inside. Okay. So for the depth, see I am rotating the CM back to 0 to look for the depth. Now here I see the needle has reached the center of the calyx there. That means you have punctured the calyx. Now once you remove the stylet of the PCNL puncture needle, you see free flow of saline coming out there. Now the beauty of the mid-posterior calyx is when you pass guide wire, it actually goes directly into the ureter because it is straight to the PUJ. That's why this is one of the better calyx to puncture because the anatomy is always defined here because the anterior posterior orientation is defined always. Now you see that infundibulum in front of you. So when I'm going there, you see the stone there in the pelvis. So when your infundibulum is in front of you, that means the puncture which you have done is correct. Because if you have done an infundibular puncture, you can't see the infundibulum in front of you. You directly go to the pelvis there. Here you are seeing it in front. That means you are punctured the papilla. Now coming to the another example here, just a small example just to show, because the one which I have shown is the mid-posterior calyx. Now I am showing the mid-anterior, posterior inferior calyx. Now you see here also a white area is seen here. You see the stone lying in the anterior calyx here. Now I am targeting the posterior inferior calyx. See, it is also moving medially when I am doing the CM from 0 to 30. See, it has actually overlapping onto the pelvis there. So this is the mid-posterior calyx, posterior inferior calyx. Now with bullseye technique, again I am aligning the needle there. And after you align it, CM is aligned in that axis only. Same technique, I am slightly forwarding it for the lack of time. Now you see I have entered assessing the depth of the needle there in 0. Now again I am aligning it in 30. So in that way you pass the needle inside till you reach the calyx. Now you see free flow of saline is coming there. Now guide wire goes into the ureter. Now I'm just showing the scopy for our understanding, which we have seen. See, this is a posterior calyx. You are going directly into the PUJ. Now the advantage of posterior calyxal puncture is that your anterior calyces are seen in a dependent position. You see the stone is lying down. So I can easily break it and then remove it. So this is one example which I am showing. And let us go to the next technique. That is a triangulation technique. Of course, triangulation technique is slightly difficult when compared to a bullseye technique. Here, the puncture needle is not in line with the CM. So that's what I'm showing. Why the name triangulation is, your needle is here, whereas you are using the CM to see in an oblique angle to pass the needle to reach the calyx. So that's why, since you are seeing it at an angle, the word triangulation is come up. Now, if you see here, the first position I'm showing here, the movements of the triangulation technique. First, align the needle in 0. Now, move the CM cephalad. Now, see the CM is rotated up. Once it goes up, now the needle is actually not in line with the CM. See, it is it is at an angle. So that's why in triangulation, you have to rotate the CM in at oblique angle, one in 0, the other in 30 degrees, but the CM is cephaloid. So these are the movements which you use in triangulation. Now you see the needle is here, but your CM is in a different axis. So for understanding how to puncture, this is the example which I am showing. This is the same example which I have shown before, where we did a mid-posterior calyx. In the same kidney, I did the triangulation as well. Now I am showing this. Let me come back to the position. So now you see the needle I have placed in the 0 degree. Now I am rotating the CM cephaloid. Now once we move it to cephaloid, you rotate the CM to 30 degrees. Once you do that, there are two movements. See, I'm moving the CM towards me. So when I move the CM towards me, at this axis, it is at an angle. The needle has two movements, medial and lateral. Now see, I am adjusting the medial and lateral in this axis. See how I am doing fluoroscopically. The needle is now like this. The calyx is here. So what I do, see, medially I moved the needle. So I am turning the needle in line with the calyx. I rotated it. Now again, move the CM back to 0 there at that angle. And in this angle, the needle movements will be cephaloid or cranial. Now see here, I am moving my needle cephaloid or cranial. Initially, I did mediolateral. Now cephalocaudal. See, I did cephalocaudal now. Now, when I do the cephalocaudal, you see the needle is going up. Obviously, I am trying to reach that calyx. Now, pass the needle a little bit inside. Again, do the same movements in both axes. So that means at each point, you are adjusting the needle in two axes, one in 30, the other in 0 degree. However, the CM is not in line with the needle. It is at an angle. That is, it is cephaloid. So that's why the triangulation technique is technically a little bit difficult for beginners when compared to bullseye technique, because in bullseye you fix the needle in one axis and just go and puncture the calyx. That's it. Only thing you are going to see is the depth of the needle. See here I am adjusting again, medial lateral. Now I rotate the CM. Now I do cephalocaudal. See, now I push the needle up because the calyx is down. So I am pushing it up. Now see, then I enter inside. So that means the needle is being adjusted every time with two movements, mediolateral and cephalocaudal. So once it reaches the calyx, obviously, again I am adjusting, see, it goes inside. So I hope residents have understood these movements, mediolateral and cephalocaudal. Now once you are inside, you see free flow of saline. Now the next step is, of course, passing a guide wire there. So this I am going to skip here. So these are the basic differences which you see, the bullseye technique and triangulation technique, which I have summarized here. That CM is parallel, it is not parallel in triangulation. Mediolateral and cephalocaudal adjustments of the needle are done in a single fluoroscopy view, whereas it is done in two fluoroscopic views in triangulation technique. That's why it is difficult. Whereas the depth of advancement of needle is monitored in fluoroscopy in one view only, whereas in triangulation, you monitor the depth of the needle in two axes. Now, for a superior calyceal puncture, you keep it at 0 degree. The puncture is slightly different. You keep the needle in 0 degree along the calyx. Whereas for the depth of the needle assessment, you move the CM into the reverse 30 position. This is just an example to show the superior calyceal puncture. This will complete all the punctures. Now you see in this system, just you can see the superior calyx is a compound calyceal system. You can see a faint rounded area here, which is a perpendicular minor calyx as shown in this figure. So this is the calyx which you are seeing here. So now if you see, I kept the needle in line with the 0. You see the needle bullseye technique I am doing for the superior calyx. So in this, I pass the needle inside. Now for assessing the depth of the needle, I have to rotate the CM in a reverse 30 position, because here the calyx is there. Now see, the CM is rotated to reverse. This will show me the depth of the needle. Now you see the same calyx, rounded calyx which you are seeing, the needle is still away. So what I do, I again rotate the CM back to 0. With the bullseye technique, I am passing it inside. Now again I see the position of the needle in reverse 30. See, it has reached the center of the calyx. Now after that, obviously, once you know that it is there, you remove the stylet, you see free flow of saline coming, and then you dilate. Now just I skip this one. Of course, ultrasound guided axis is another technique of doing the same puncture. Of course, you use the ultrasound transducer with the puncture guide. For the lack of time, I think this is a separate topic which has to be discussed. How it has to be done. Where you using the puncture guide, you align the posterior calyx and then puncture it. Do you have 5 minutes more? 5 more minutes time?
Yeah, you can quickly touch upon that. Yeah.
Okay. So if you see in while doing the ultrasound guided puncture, I will show how to scan the kidney.
You can see the posterior calyx there. When I go a little bit laterally, see I am going laterally, it comes and now mark it on the surface of the kidney. The ultrasound.
See, this is the first initial step. Close to the spine, you align the probe in the axis of the kidney.
Long axis of the kidney. And you
start moving from medial to lateral. So when you start moving from medial to lateral,
which points out,
the first calyx which points out to you is the posterior calyx. So that's how you identify you scan the kidney, and then you identify it. Okay, then after that, this is how we keep it.
Line with the.
So this is a puncture guide marker. Also, you can switch it on the ultrasound monitor. And once you fix the location, you identify the location of the skin. Give local. Of course, this is I did it in local. I am showing for a PCN placement using the puncture needle in that axis.
So when you are doing with a puncture guide, there is no need to worry because the needle goes into the same track which was shown on the screen. See, you can see the movement on the surface of the kidney. Then it slowly the needle enters into the calyx. Now you can see the tip of the needle seeing bright there.
The most important step here is that needle should be aligned along the line of the probe.
Inside,
if there is puncture guide, it is very easy for you to align it. So that's how you puncture it. Okay.
Very important.
And rest of the steps are dilatation are same. I don't think that we need this. Now other technique is the endoscopic guided puncture. This is as a part of completion I kept it where you pass a ureteroscope in this position, and then you under the endoscopic guidance you puncture the kidney. Then the tract dilatation, you have amplage dilator sets, balloon dilator sets, and the Alken's metallic serial dilatation. This is the set which you have where you have the puncture needle, you see the PTFE dilators too, and this is the Alken cannula. And these are the serial dilators, which are telescopic dilator. One over the other, you pass this dilator till you place the amplage sheath. So I was just showing a patient where we were doing the guide wire in place. The first dilator, 6 French dilator is passed. So slow screwing movements, you pass it. And the most important thing is always pass the dilator till the calyx, not to push it too much inside. And the C-arm should always be kept in 0 degree position to know the depth of entry of the dilator. Now here I am passing the Alken cannula. The Alken cannula, you can see it is passed there. Yeah, keep it at the tip at the level of the calyx only. Then the outer sheath of the Alken's cannula is passed inside, the inner cannula is removed. Now always Alken's cannula helps in confirming the position of the cannula in the kidney. So when somebody injects saline, you get saline here, which confirms the position of your cannula. Then the guide rod, which is passed through the Alken's cannula. So always position it there in the calyx only, then remove the outer sheath of the cannula. Then one by one, my assistant is giving me the dilator. So I will be holding the guide rod and then I am passing it one by one. So it's a controlled dilatation. Always you should not use too much force. Suddenly, sometimes when it gives way, you will go and injure the opposite wall while dilatation. So you have to be very cautious, holding it and with rotatory movements, slowly. You see how I am rotating and I am passing it gently. And it should be continuously for fluoroscopic guidance have to be taken to position the tip of the dilator in the calyx. Okay, so I'm passing the rest of the dilators. Initial dilators go very easily, but the rest of the dilators, obviously you have to use some force to rotate and then pass it. So once the dilator reaches the tip, you get saline here. So with the rotatory movements, I am passing one by one. And finally, the final step is passing the amplage over it. I think everybody know this step. So it is rotated there, and then you always that safety guide wire should be there while doing pre-senal. And you see free flow of saline coming over there. Once you enter, you can see the stone lying in front of you in the calyx there. So I think but the main steps of techniques I have shown, and the guide wire should always be preferably kept in the ureter. Sometimes guide wire coiling like this, if you dilate, sometimes the guide wire might slip, or suppose I have seen cases where the guide wire was actually coiling outside the system and the dilatation has been done, leading to injury to the PCS. So these are difficult cases where if the guide wire doesn't go into the ureter because of an obstructing calculus, you have to be very careful in such cases while dilating the tracts. And the intraoperative procedure, of course, the pneumatic lithotripsy or laser are the techniques which you use to ablate the stone. And so the most important tips is that always keep the safety guide wire in place, and the assistant should always hold the amplar sheath when removing the fragments. Otherwise, sometimes the amplar sheath might dislodge. And whenever there is excessive torque, you should not try to use the torque to reach the other calyces. It is better to consider puncturing the separate calyx rather than using excessive force. Like in this case, you see there is an angle here. In this case, I was actually doing the clearance of the stone, and I thought there are some fragments in the superior calyx. I thought, let me go a little bit if it allows me. But suddenly, what happened? When I was doing this, you can see when I went to the superior calyx now. I had some resistance, but it went inside. But when I came back, you see there was a tear in the PCS here. So that's why excessive torque should be avoided while doing PCNL. You can see the sinus pad there. So it's always better not to avoid when there is excessive torque. Don't push the scope forcefully, or else you will injure. And when you are dealing with radiolucent stones, it's always better to inject contrast at the end of the procedure. When you place an nephrostomy to see whether you have completely cleared, because these stones are not seen on fluoro. And the exit strategy, whenever there is a large stone bulk, you want to stage the procedure, or when there is intraoperative complication like PUJ injury or bleeding, you place a nephrostomy or a stent. So this is the video showing how to place the nephrostomy over a guide wire. So I'm removing the amplar sheath over there. And always it's a good habit to inject local whenever you're doing standard PCNL, because the patient do have pain in the post-operative period, and then do the dressing properly. So I conclude my presentation saying that always it is very important to study the preoperative imaging before planning initial puncture during PCNL, because the IVP or CT, when you study, you will have good amount of information as to where that posterior calyx, if you are willing to puncture, where it is lying. And then a good initial puncture is almost an important part of achieving a successful outcome during PCNL. Thank you.
Thank you, Sudheer, for the excellent demonstration of the technique. And now the session is over to Dr. Pal sir and Dr. Madhu sir for the discussion. And we can answer the questions from the chat box also.
Dr. Pal, would you like to give your comments first?
It was an excellent presentation, Dr. Sudheer. But for the benefit of my junior colleagues, I would like to say that although PCNL is now 40-year-old technique, but still there are so many controversies from each step. Which technique to follow, whether the patient should be under spinal or GA, whether it should be this calyx, that calyx, or how to choose the calyx. Regarding triangulation technique, there are so many descriptions in the literature that a person will always get confused. Fortunately, all the techniques are successful. It is said that if you have done a good puncture, you will always land up into a good result. But Peter Elkin has now recently put an article where even a good puncture has resulted into a bad outcome, and a bad puncture has resulted into a good outcome. So, dear friends, those should not, my junior colleagues, they should not lose heart. They should follow with one technique and master that. Initial 10 PCNL, they should always have a senior person behind them, because if they fail repeatedly, they will be disheartened and PCNL will not be learned. It is a good technique. Everybody should know it. So they should have one person standing behind them for the first 10 cases. For the first 60 cases, they should put the safety guide wire also. That is also very important. We should have included in the step where we should put a safety guide wire. And after 100 cases, They are as masters as anyone else. They should be confident enough and they should do PCNL surgery. It is a good technique and it will come to their rescue even when the RIRS fails. So these are all the inputs I would like to give to my junior colleagues. They should learn, follow one technique, whatever you have learned, whatever your teacher has taught you, expertise it. First 10 cases, somebody behind you. First 60 cases, you should have a guide, some safety guide wire, and then all whatever this technique you are familiar and comfortable, follow that. Don't get confused. Over to Madhu, sir.
Sudheer, can you stop sharing your presentation?
Sir.
It was an excellent presentation. Sudheer, the initial steps that you showed are very important. And I think the message that you gave was very clear. And like Dr. Pal said, 40 years and still counting, and we are still learning. And we are all learning, actually. Every time we have a program, and we've been doing perks for exactly 60 years now. Pal Saab and myself, we all started in 1984, 85, and it's exactly 40 years. So, but yes, the simplest technique to learn, and like you said, we will recommend very strongly that anybody who wants to start learning perks, bullseye is the easiest to start because you can hardly go wrong. All you require is a good selection of case. And I would like to add here that anybody who wants to start perks, choose your initial cases well, because if you lose your initial case, and I have known people who gave up on PCNL because of their initial failures, then it is very disheartening. So choose a moderate sized stone in a moderately dilated kidney. Don't choose a very small stone. Don't choose a very large or staghorn stone. Don't choose an undilated pelvic calyceal system, and don't choose a very dilated pelvic calyceal system, because these are the ones where you have pitfalls. So choose a moderately dilated pelvic calyceal system and a moderate sized stone, and choose a bullseye puncture for initial confidence. And then you can go to these freehand techniques, which can be called triangulation, or you can learn from the airplane landing from Dr. SK Pal, whichever technique comes best to you. But the message is that you have to learn one technique well and then practice it. And once you gain confidence, then you can experiment and try other things. The only other thing I would like to add is that there is a time now to move forward beyond fluoro-guided puncture to ultrasound and endoscopy, because that is where future belongs. And maybe we can do some more work on that in coming time.
Touching upon the few questions from the chat box, is putting bolster recommended during positioning? Anyone can answer that from the residents for the senior.
Yeah, I'd like to say something on that. In the past, bolsters were considered compulsory. We gave up on using bolsters a long time ago, and now the cycle is actually reversed. We are now flexing the patient, like Dr. Sudheer showed, putting something under the kidney to flex the patient, and in fact, breaking the kidney. So bolsters are, at least in my practice, we don't use it. Dr. Pal and Dr. Sudheer will be able to add on this.
Yeah, I fully agree, sir. We also routinely don't use bolsters, but only occasionally when you have a obese patient, where when once the anesthetist says that when the patient is made prone, the airway pressures are very high, just to decrease the some amount of pressure onto the abdomen. So the horizontally the bolsters can be placed to decrease the compression onto the abdomen. Otherwise, most of the times, as you rightly said, we don't use bolsters at all.
Agreed. Obese patients, yes.
Yes.
Other question is about the using the hybrid guide wires.
Can I also add a comment here for the bolster? Yeah.
Yes.
So I think it depends on the preference, individual preference. A lot of people, I recently heard Dr. Pal championing the cause of the standard stainless steel guide wire, but we've been using Terumo for a long time. And I'm very happy with Terumo because it is flexible tip, doesn't perforate the pelvic calyceal system, and finds its way down the ureter better than others. The problem with the hybrid is that the shaft is stiff, and the tip is soft, but the shaft is stiff. So it is good in a way, but in our own personal use, I don't find it better than Dermo.
Yeah. So with regards to bolsters, there are two, three things. One is the anesthetic, the respiratory component. The second aspect is the positional changes that happen to the kidney and the counter weight support which is provided when the kidney is being punctured. So in both of these aspects, there are definite papers which do suggest that it does help in a way. And if you are doing a stag-on case, then the issue of cushioning of the bones, which is the chest wall being pressing against the OT table, that also becomes an issue. So it is good to have bolsters. And there are papers to suggest that if you are trying to puncture the upper calyx, then it is better to have flex on the, as Dr. Sudheer also showed, to have flex on the abdomen. And that helps in orienting the calyx also, and the pleura also shifts just a little bit, maybe 1.5 centimeter upwards. So that does help, but in most of the clinical cases which are of short duration, it may not matter much.
Thank you, sir. Thank you, Sudheer, for the excellent demonstration.
Bolsters are meant
Yeah,
for
Dr.
two
Pal, sir.
purposes only.
Yes, sir. Yes, sir. Dr. Pal, sir.
Bolsters are meant for two purposes only: a better saturation, and that is between tuning between you and your anesthetist. Sometimes putting the bolsters will increase the saturation, and your anesthetist sometimes will be more comfortable when the bolsters are in place. Secondly, we should reduce the length of the track, and therefore kidney should be as close to the when you are doing prone position, and there should be a little bit of counter pressure, like Rishi mentioned. So that when you are advancing the needle, the kidney itself should not move forward, because kidney is a very mobile organ when the needle is going in. So for these two purposes only, bolsters may be of help. So you have to tune with your anesthetist and regarding how much stability you need. Thank you.
So regarding guide hybrid wire also, another one point which I want to add, like when you have a kidney which is mobile, or when a patient had a past history of PCNR and there is scarring over the kidney, when you are dilating, the kidney is actually moving. So in such situations only, I think that the hybrid guide wire would be useful, where your wire is stiffer than the Termo. So with some amount of force, actually you can try to dilate it. I think rest of the thing, most of the time, the Termo guide wire is enough.
Yeah, thank you, Dr. Sudheer. Thank you, Pal sir, Madhu sir, for this excellent insights on technique of PCNL. Now we are moving on to the next session. That is important session, because rather than teaching only urology, we want to teach our resident this important skill, that is the soft skill, how to talk to the patient, how to break the bad news. And to speak on that, we have Dr. Samit Trivedi, and to chair this session, we have good soft skill persons as a chair, Dr. Shivam Prideshi, Dr. A.K. Shanwal, Dr. Samit Chaturvedi, and Dr. Ashish. So will be Dr. Samir. Dr. Samir, over to you.
Thank you, Girdhar. And am I audible?
Yes, sir. Yes, sir. Slides are visible. You are audible.
Sure. Thank you. Good afternoon, everyone, respected chairpersons, and thanks, Dr. Rishi, Girdhar, for this opportunity and specifically choosing this topic. This is something which has not been discussed very often in the meetings, and probably a very important component of communication with the patient. So I'm happy that this topic has been chosen. And we know that breaking bad news to the patient is not an easy job, and it gives a lot of stress to people. And the implications of doing it properly go a long way in establishing a trust with the patient. So this is something which we need to highlight more. And what exactly is bad news? A lot of people mistake it for delivering it as a news of death or a terminal illness. That is not exactly true. Bad news can be something which, according to the definition which is most accepted by Buckman, any news which drastically alters the patient's view about his or her future. So the key word is that you have to take into account the patient's expectations. What is the patient's perspective? So as per the patient, you'll have to tailor. So what is bad news for a particular patient may not be bad for another one. So for example, a pregnant female coming to know that the baby is having some congenital deformity is maybe a very bad news for her. So you have to always ask the patient what exactly he thinks about his condition and then decide what is the magnitude of the bad news as far as the patient is concerned. Why is it important to discuss about the correct delivery of bad news? Well, the important thing is if you do it in a proper way, the patients start accepting the reality, starts getting adapted, their treatment adherence goes up, and they are able to make the necessary adjustments in their psyche so that they can deal with the whole treatment process. The second component is it's also important from a physician's point of view. The studies have shown that people who deliver this bad news in a proper way, in a more comfortable manner, suffer less stress, less burnout. And of course, we know that communication forms the cornerstone of your future relationship with the patient and the families. Poor communication happens to be the single most important cause for all the litigations, and in our country, even the manhandlings and beatings that frequently happen. So a good communication is important, and breaking bad news is one of the important components of that. Why people feel uncomfortable? What is so difficult about delivering this bad news? Well, main reason is we have not been taught about it. Our medical curriculum does not simply include lessons on communication. Nowadays, they have started changing it, but our generation, we have never been taught how to talk with the patients, how to communicate, how to pass on the bad news. And studies have identified this as the main factor why physicians experience so much of stress after breaking bad news, which can last for a long time. We simply don't understand the complexities and the nuances of emotional upheavals that are involved in this process. So before we pass on the bad news, we must identify the barriers which are there, which come in the way of breaking these bad news. And these barriers are important from the physician's perspective. The physicians may be afraid of being blamed. They may be afraid that they are simply not knowledgeable enough to answer all the questions. They are afraid of eliciting strong reactions from the patient or the families. So we should be aware of these barriers, and we should try to overcome these barriers before we deliver the bad news. Then who should be the bearer of this bad news? Should the messenger? Who should be the messenger in this? Normally, this responsibility is often passed on to either nursing staff or junior colleagues or residents in many of the places. But ideally speaking, it should be the chief consultant, somebody who has seen the patient has trust in him, the patients have come to him for consultation. So he should be the ideal person to deliver this bad news. Of course, he has to be familiar with the patient and their families. So sometimes in teaching institutes like ours, residents spend a lot of time with the patients and their families. So anybody who has got a rapport with the family might be the correct person to do this job. Important thing is the whole team should be in the loop. All the team members of the treating team should know what has been told to the patient and the families, and they should all follow the same chain of thought, and there should not be any discrepancy between different members, because that leads to a lot of confusion and even litigation and cases of mistrust. When should you give the bad news? As soon as the condition is diagnosed, or can you delay it for some time? Well, that depends from patient to patient, depending on the condition, what kind of bad news that you are planning to deliver. Ideally speaking, as per ethics, the patient should be made aware as soon as the news is confirmed. But then sometimes it may not be an ideal thing. So if it's an emergency, for example, a patient being diagnosed as HIV positive, now you'll have to immediately start taking the universal precautions. In such cases, it becomes imperative to pass on the news immediately. Whereas sometimes in some conditions, you get that window of delaying it for some time to a more convenient situation when more family members and supporting friends and families of the patient are available, and then you can deliver this news gradually. The advantage is it gives the families and the patient some time to adjust emotionally to the bad news. The drawback is, since they don't get the whole picture upfront, so they may not be able to make necessary adjustments in their lives as per the prevailing situation. Where should you give the bad news? What is the ideal place? Well, one thing you should definitely not do is give such news in public places like corridors or elevators or a crowded consulting room. Ideal place is a private room with a lot of privacy, an environment where patient feels comfortable. He has got either some family members or friends with his prior permission who are there for providing support. So this is the kind of environment which is suitable for passing on the bad news. Now, this is one thing which is very fairly common and a dilemma which we often face. Whether we should tell the patient about his condition, whether the patient should be informed about the bad news. Now, traditionally speaking, since time immemorial, Hippocrates advised against it because he felt that it can have a negative impact on the patient's psyche. The patient may take a turn for the worse and the condition may deteriorate. Even the AMA, since till quite late, continued to follow the same policy. And a lot of us have been following the same policy, that we try to kind of protect the patient and not give him that emotional trauma of hearing about the bad diagnosis or an adverse prognosis. But fortunately, in recent times, this ancient attitude of silence is changing. The studies have shown that most of the patients, in fact, prefer to have a complete disclosure of their diagnosis, what is the outlook that they are facing. So it depends from patient to patient in different circumstances whether the patient should be told the whole truth or not. By going by patient's rights, it is his right to be told first and not the family. That is what the ethical issues dictate. So if you want to share his information with the family, ideally it is better to obtain the patient's permission first. But again, there are a lot of cultural issues involved in this. In a country like ours, where the family ties are so strong, that we may skip this step and maybe discuss with the family how much to be told to the patient. Whereas in Western societies, it is strictly the patient first, and only with his permission, other family members can be informed. So this again depends on your reading of the situation, and you can make the necessary adjustments. There are, of course, certain situations, for example, minors or children or patients who have got cognitive issues, where it is necessary to take the family into confidence and apprise them of the whole situation. So that's a different situation. Now, this is again a common scenario which we face. The family says that, please, Doctor Saab, do not tell the patient. आप patient को मत बताइए. The patient may not cope up with the news, or he may be depressed, or he may not be able to adjust to the situation. Now, strictly going by morals and ethics, this is not justifiable. The patient deserves to know about his situation, about his disease and the prognosis. So the ideal thing would be to tell the family that, look, the patient needs to be told about his condition. He has to be aware of it. But again, like in the previous scenario, you have to take the whole picture into account, discuss with the family, try to convince them that the patient needs to know about his disease, but don't antagonize the family, because they are going to ultimately play a very important part in the future treatment and the counseling and follow-ups. So try to convince them. If they continue to resist, you can even suggest them to maybe discuss it with the patient, how much information has to be shared, and then accordingly take a call. And although ethics do not allow it, but we have to sometimes bend the ethical practices a little bit in order to see the overall well-being. This is one of those situations where if the family continues to be adamant, then maybe you can be a little flexible rather than antagonizing or taking a totally confrontational kind of attitude. We can discuss with the family and maybe take a path somewhere in the middle. Coming to the main, how to break the bad news. Well, it's not a simple thing. There are well-described protocols about how to do it, and there are various protocols that have been described. The oldest one and the most commonly one followed is this SPIKES protocol, which was suggested by Roger Buckman way back in 1992. And this is an acronym, the SPIKES, and which stands for the 6 steps that need to be followed. So I'll discuss this in slight detail, and the other protocols, we'll briefly touch about it. So the first step is to setting up the place. So kind of background. So you choose a place, before meeting with the patient and the families, you make a thorough review of the patient's record, get yourself familiarized with the patient's clinical information, kind of have an approach in your mind about how you're going to do it. It should be a private, quiet room, allow enough time for discussion, don't have any interruptions like mobile phones or any other disturbances. Try to give the patient some time, make the patient comfortable, and be in a way kind of convey the impression that you are serious about the whole thing and you are trying to tell the patient something which is of great significance. So this will be the first step. The second is the perception. Before giving any information to the patient, try to find out how much does the patient know, or what do they suspect about their condition. When the patient is telling you about his perceptions and expectations, try to gauge the level of intellect, the level of comprehension, the language the patient is using, and try to keep that in mind when you are responding to the patient. So if you be on the same level, then it's easier for the patient and the families to accept and grasp what you're trying to tell them. The most common reaction initially on getting a bad news is of denial, which is the most common emotional reaction. So the patient may be in denial initially, he may not be able to believe that he has got that disease. So this is not the time to refute the patient or have a confrontation and try to be aggressive. The patient needs some time to process the news that he has received. So at this time, simply let the patient believe whatever he says. Just listen to him patiently and try to get an idea about what the patient's expectations are. Third step is invitation or asking the patient about how much does he want to know. So this is the place where you ask the patient about the degree of information that he wants to receive, whether he wants any family members or any friends to be with him at this stage, and how much information does he want to find out. So different people process the information that they receive in a different way. So the patient has the right to decide how much he wants to know. And unless you ask him, you will never be able to know how much to be told, and it may end up leading to some kind of communication errors. The fourth step is the knowledge, which is the actual giving of the bad news. And this is where your role comes in. So you have listened to the patient, you have got an idea about his expectations, you have asked him how much he wants to know, and then it's time for you to give that information. So before you do it, be wary of not being very blunt. Do not be very upfront. Give the patient a gentle warning about what is going to come. Take into account the patient's emotional status. Be gentle. Do not give a lot of information at one go. Give it slowly in steps. Use a language which is clear, which is understandable to the patient and the family. Try to give pauses. Try to gauge the patient's reaction as you are speaking. Allow him to ask questions. Encourage asking questions. And make it a two-way process. Whatever you say, how is the patient processing it? How is he responding? Focus on that. So take into account all the verbal and non-verbal cues, and then accordingly proceed further. And then try to gauge what the patient is expecting and how he wants to proceed. So this is all something which comes naturally once you are aware of what is to be done. This cannot be taught like this. So you have to be aware of the situation and as well as keep an eye on the patient's responses. The fifth step is regarding the emotions and the empathy. This is going to be an intense emotional situation. You have to be very sympathetic and empathetic to the patient and the family. Be prepared to support them. There is a very high degree of potential for patient or families having outbursts of anger, denial, shock, sadness, or even blaming yourself. Do not react. Give them time to process the information. Let them vent out their feelings. You can say them this is a natural response to any big sad news, and this is a normal thing to do. Once all these emotions have been burst out from the patient, then most of the people will tend to settle down, and you can carry on, and you can expect them to grasp what you're trying to say, and maybe the patient will be able to better comprehend and adapt to the situation like this. And the last step is, once you have imparted the information, then make sure that the patient or the families have grasped what you have told them. You have given them an overload of information in a short time, and that too bad news. So there are chances that they may not be able to grasp completely what you have told them. So it's a good idea to ask them to repeat what you have told them, what they have understood, and make sure that there is no confusion, there is no communication gap in between. And then outline the treatment protocols to them. What is to be done now? Once the diagnosis has been established, the patient has received the bad news. Now, how do you want to proceed? What are the options that they have considering their circumstances? What are the realistic treatment goals which they can pursue, and how it is to be done, what is to be done? And patients can be given this information at this time. And of course, they need to be reassured that the whole team is going to be with them and they are available. You can give them a further future schedule for follow-up and when do they have to come. That kind of practical things can be planned at the end of the protocol. So besides this spikes protocol, there are a lot of other protocols which are there in the literature. Some are tailored to exclusively malignancy, some are for emergency situations. So it doesn't matter which protocol do you follow, but you have to remember certain basic steps that need to be done, the things which have to be covered, and certain do's and don'ts which you must remember. So I'll just briefly summarize the do's, what you should do and what you should not do. You should have all the facts with you before you go into delivery of bad news. You should give enough time, have a private and confidential place, use a language which the patient can understand, clarify all the patient's doubts and questions, give time to the patient to talk, listen to the patient what he is saying, allow for all the reactions, emotional reactions that can come from the patient or the families, document what you are doing, and ensure that your complete team knows what you have told the patient so that everybody is on the same page. What you should definitely not do is, you should not assume that the patient knows everything. Ask the patient what he knows. You should not give too much information at once. Do not distort the truth or withhold any information. That can be disastrous. Do not give any false assurances just because the patient is very distraught. Do not feel obliged to just keep talking to reassure the patient. Silences sometimes can speak louder than words. Do not make any judgment calls. Do not criticize the patient, and do not show that you are in a hurry and this thing is not important for you. Give the patient proper time and give him the impression that you are there for the patient and the family. Please remember that bad news can drastically impact not only the patient, but the complete family. And this is probably the greatest cyclist the world has ever known, the 7 times Tour de Paris champion. And this was his reaction when he was diagnosed with metastatic testicular cancer in 1996. And it completely changed the life. So that is the kind of impact bad news can have on a patient or his family or his career. So to conclude, please remember that the way you deliver the bad news can have a huge bearing on people's lives. How they cope with the bad news, how do they adjust. Before you deliver the bad news, be sure where you are giving it, who is giving it, whom are you giving it to, and what are the likely consequences of giving this bad news. It requires time in a setting which is conducive and friendly for the patient without interactions. Give proper time, empathize with the patient, provide support to the family and the relatives, ensure that your team member know about what has been told to the patient. And the overall ultimately game is to provide the patient an ethical way of delivery of the bad news, and of course make him comfortable, make him adapt to the bad news, and then proper treatment guidelines or proper treatments which are available to the patient that should be told to them. Thank you.
Thank you, Samir sir. Thank you for this insightful talk, and I learned a lot of things that I didn't know beforehand, and it was really useful for even for me also, not only for the residents. And we can have more panelists, Dr. Shivam, Dr. Samir, Dr. Sanwal. They have more experience and more soft skills to discuss about it. Sir.
Thank you. With the permission of Girdhar and my co-chairpersons, can I come in?
Yes, sir. Sure, sir.
Thank you. Thank you very much. I'm wishing everyone a very happy Republic Day, and thanks for the opportunity. So first of all, congratulations to Samir. Samir has done his job very well, very effectively, and in a very simple manner. He has given a very important message. I think we all lack in this particular subject, which is very important, the communication skill of our doctors with the patients, and particularly when it comes to breaking a bad news. In North Zone, we definitely had a lot of workshops also. I remember a workshop in Kota about doctor-patient relationship, and then we had about communication skills. I think this is very important, and you people have taken up this task, and I must congratulate all of you. I think when breaking a bad news, it's very important. The 3 important aspects are, one is the empathy towards the patient, have professionalism in whatever you communicate, and very important is a careful communication to the patient so that you can be compassionate and effectively communicate what you are going to put the news to the patients. And the Dr. Samir, which he told about the protocol, the SPIKES protocol, and I think that all residents who are listening, they must remember these 5 points very much. The SPIKES protocol, where S stands for setting up the interview, P stands for a patient's perception, I stands for inviting the patient, and K for gaining knowledge, E for the emotional aspect, and S is the strategy and the summary. So always remember these 5-6 points before you have this. You have to communicate with the patient and break the bad news. So I would now invite my co-chairpersons to have their comments, and then if any question is there, we can all discuss.
Dr. Samit, have you any there? Dr. Samit Chaturvedi.
Yeah, good afternoon. Thank you, Dr. Girdhar. Excellent presentations, Sameer sir, and thank you for words of wisdom, Dr. Shivam sir. 3-4 practical points that I wanted to say is you must have, as Dr. Sameer has said, you must have all the information. You should see all the reports yourself before you go and break the bad news to the patient. Not somebody, your junior has told you that this is the report and you go straight away and talk. Because then it will be a half-baked information and they ask questions, you will be fumbling and it never looks good. Second, when you are breaking a bad news, you need to say that we as a team are with you. That is the part of empathy. Don't be the only one to know and do everything. So it's a teamwork. So say that we are with you. And empathy is all right, but you should not feel guilty about giving this diagnosis, because that guilt conscious, if the patient perceives or the attendants perceive, they can be offensive. So I tell all my residents that you are not the reason for the disease or the terminal illness. You are the one who was telling them, who is telling them this, but you should not feel guilty. You may feel bad that the patient has a terminal illness, but you should not let the guilt take over you. Third thing is timing. Once you have broken the news, that is what we do in the morning. If you have given the news to the patient and relative, go and visit in the evening or the next day morning. Let the message sink in, let them have questions for you rather than give information at one time and then you are not there for them to, come back to you. So either on the same day or the next day morning, please meet them again. And as far as the news, the relatives say don't break the news to the patient, tell them very clearly that it is not whether we break the news. The only thing that you can consider is when you break it to the patient and how you break it to the patient. So not in the same visit, maybe the next visit, or the way you break it. Most of the patients will have some idea that something is wrong. So you can ask them that, what do you want to know about your disease, whether you want to know more about it. So it's not whether you break it to them, it is when and how you break. You need to ask the family. Rest, I think Sameer sir has covered everything pretty well. Thank you.
Sometimes patients ask some question that you don't have the answers. So what do you say? I don't know, or you will just play around it, or how you do it? Because sometimes they ask. Yeah.
Shivam sir, please.
I think you have to be smart enough in that. That's where the art of breaking news comes in. How to break the news and how to give answer to the patient. You should smart enough. If you do not know particularly, you should be smart enough how to circumvent the whole thing.
Let's say they say कि कितना time बचा है हमारे पास, मेरे father के पास, how much time is left? How to deal with that issue and how to take it forward?
Yeah.
Can I answer that?
Yeah.
Samir, go ahead.
Yeah. So first thing is never ever commit a time frame. Never ever commit a time frame to a patient. What you can do is you can tell them that, look, in terms of statistics, the median survival for this disease at this stage is maybe 6 months to 12 years, but then you are an individual, you are not a group. That applies to a group. So exact time frame, try to avoid. You can give them an idea that, look, most of the patients who have got this kind of disease at this stage tend to survive for this many months or this many years. So you always have a window of escaping. Suppose the patient does not survive that long. The family might come back to you, sir, you said 6 months, he has died in 3 months. Or if he survives for 1 year, they might come back and say, sir, आपने 6 महीने कहा था, वो तो 1 साल हो गया, अभी भी जिंदा है. So keep that window room, regal room open to you. Never give a time frame for an individual patient.
Yeah, thank you, Sudheer.
I think here we need to touch upon the evidence base, what exactly the evidence says, and we never have to be very particular about the time, but we can say that yes, this percentage of number of patients usually survive for this average period. So I think that is a better way. When Dr. Samit said about the guilt while having communicating, I think this guilt comes in sometimes when there are complications during surgery, and then you have to break that news. So again, it's very important to be very smart enough, and very effectively you have to break any kind of a complication, telling the patient that yes, this has happened and this may happen. And because definitely you take a consent before doing a major surgery, telling them all kind of complications. So you said yes, this has happened, and this usually might happen in such a percentage of patients. We have done our best, but still it's happened. So I think you have to explain the patient the complication, and that is, I think, very important to the patient. One thing, just before Dr. Sawal has his comment, when I was a house officer and in Calcutta Medical College, in Kolkata. So what you used to do every evening, we used to have a patient party meeting, right? So all those patients who have been admitted, we will ask the attendants to come one by one and tell them that this is the position of the patient, this has happened, and this is what we want to do. I think this is a very important thing that we need to do with the patient. Patient's attendants also must know what is happening to the patient. So I think that was what I wanted to say. So Dr. Sawal.
Dr. Sawal's comment, please.
Dr.
I'm standing from but I was able to
Your voice is not clear, Sawal.
Your voice is clear.
Is my voice clear? Is my voice clear?
Better.
Little bit better, sir. Yeah.
Okay. So it is a little bit section, but hopefully it's okay. Like the main the word political part and also given the provision sentence. But it comes to one person, and in the situation it may become easier. But if somebody is having a private setup, so single person, 2 person, it becomes very, very important, because most of the time these are the relatives which actually create problems, not the doctors. So one should find who is the most important person in the relations. And in many relations, there are intelligent persons, there are medical persons who can understand the implication of the background. One should take this time, call that person, and then gradually explain. Of course, there should not be a time frame. But if you can find a reasonably good person whom you can explain the backgrounds, probably because this is a certain exposure to a thing which they don't expect. Certain complications. Complications is the most important thing. That is something certain there. I mean, anesthesia, some reactions and PCR is also something like that. It is the most difficult part. So if you are able to find the most important person, then it will become easier, because you can understand the point, you can explain the academic points also for complications. And then if you are explaining it to the patient on his relation, not be very well educated, he will definitely. Second and most important point is you should assess the patient's value of the persons and relations. Because the patient himself has not matched it. When you find it is the relations which are important. And if you cannot handle it, find your colleagues, call them. Even if you cannot have, even your colleagues cannot have, beforehand you can call the police. Incidents has happened sometimes back. A patient was not in our facility, gynae patient. She had some PPH, and patient was died, and thousands of patients came. So that was the time police was called beforehand. It was so it depends upon the situation. If head of the department, a resident who is taking care of, he can, so that is okay. is not the most serious person who is able to diagnose it. Okay. If even after that, you should not hesitate. And I mean, sometimes you can shift to the patient. Somebody picks some patients that shop and something you cannot tell. You can shift it to better experience. And then there is that will basically, because you should also, it is not only the patients which are important. Now the relation has become very, very important. And you should show how to treat. So everything.
Yeah. Thank you, Dr. Saval. I think
So we are not able
his
to
voice
hear you
was not
clearly, but we know
clear.
the feelings and.
But I think what he wanted to say, the body language told it, right? So again, the body language is very important while communicating with the patient. So how is your body language in communication? There was one question from Dr. SK Pal that sometimes the attendants want the patient to go out of the room before you break the news or something like that. I think, again, Dr. Sameer had already dealt with it, how to do it ethically. It doesn't allow. But again, considering the situation, I think we need to tell the attendants that, see, we will tell the patient in a very kind of a manner which will not just hit him straight away. So again, after convincing the attendants, we need to ask the patient to come and say, see, this has happened. And like suppose there's a cancer, we can say, right, yeah, एक गांठ है जिसका ऑपरेशन करने की जरूरत है और ये सारा है और इतने सारे मरीज जो हैं उसके बाद में ठीक हो जाते हैं, ऐसा कुछ नहीं है. So you have to understand how to tell the patient, but definitely you need to tell the truth to the patient. Yes.
कई बार इसमें उसके आप
Yeah.
immediately patient को नहीं, then it becomes much easier. And gradually patient moves. Sometimes patient is having carcinoma. It's an old patient. आप उसके son को बुला करके के पास बताना इसको कैंसर, and then gradually take his family and then get the patient. It becomes much easier.
Yeah, thank you, sir. Thank you, Sameer, sir, for the insightful and talk and giving the spikes protocol to all of us. I think we should paste that protocol into our office or OPD and revisit this spikes protocol more and more so often. And thank you, Shivam, sir, Samit, sir, Sanwal, sir, for their insightful thoughts. Now, moving on to the next session, that's an important session that is a drug spotlight. We commonly pick a commonly used urology drug. Last time we did alpha blocker. This time we have chosen androgen receptor blockers. That we left and right we are using these drugs in our common practice, and we should know the pharmacology, pharmacodynamics, pharmacokinetics, and the side effects of these drugs. To speak on this topic, we have Dr. Sudheer Yadav. He is a consultant urology at Safdarjung Hospital. And to chair the session, we have Dr. Nayak from AIIMS Delhi, Dr. Gautam Chaudhary from AIIMS Jodhpur, Dr. Himanshu from Varanasi, and Dr. Amitabh from RGCI, and Dr. Syed Sujan Najib from Kashmir. Dr. Siddharth, can you share your screen, Dr. Siddharth? Dr. Siddharth.
Yes, sir. Okay.
Good morning.
Good morning, sir. Hi. Thank you for the opportunity. I'm unable to share my screen. Just a moment. I think. Can you see my screen?
Don't worry. It will be done. Yeah.
Can you see my screen, sir?
Yeah, you can see it. Make it full screen.
Yes, sir. Just a moment. Is it full screen now, sir?
Yeah. Go ahead.
Yes. Thank you, Rishi sir and Bora sir, for giving me this opportunity. I'll be speaking on androgen receptor blockers, the basic pharmacokinetics, dynamics, and adverse events of these drugs. So testosterone is the driving force for prostate cancer, as we all know it. And there are three major sources of testosterone or androgens that work in patients with cancer prostate. The 95% of testosterone comes from the testis, which is under the direct control of GnRH or LHRH secretion from the pituitary. Whereas the rest of the 5% comes from the adrenal gland, which is under the ACTH secretion. The third source is the intratumoral, which we'll be discussing at a later time. And androgen receptor plays a very, very important role in the growth and survival of the prostate cancer, as it is the final downstream pathway for all the androgens working on the cancer cells. So with the, in recent times, in the past couple of years, a lot of new terminology has come in, and I've just summarized all the newer terminologies here in this slide. which have been used very interchangeably, and they may or may not talk about different things. The first is NSAA, which was traditionally used as non-steroidal anti-androgens, but now it is also used for novel non-steroidal anti-androgens. ARBs are androgen receptor blockers. ARPIs are androgen receptor pathway inhibitors, and a new term is SAGARI, that is second generation androgen receptor inhibitor. One new term of importance is NHA. NHA is novel hormonal agents, but includes second generation ARBs as well as abiraterone acetate, which has a different mechanism of action. It's not an androgen receptor blocker. So as far as the androgen receptor blockers are concerned, they're classified into three parts. The first and the oldest one are the steroidal anti-androgens. Then came the first generation anti-androgens, which were in vogue in the past decade. And currently what we are using is the second generation anti-androgens, which are definitely being used these days more and more and have become the first line of treatment. So let's discuss with the first one, just a quick brush up about the steroidal anti-androgens. Now, there were three main: cypertron acetate, megestrol acetate, and medroxyprogesterone. Now, these molecules used to have dual action. They were competitive inhibitors of androgen receptor, as well as had progestational effects in the center, and in the center, that means hypothalamus and pituitary, which led to suppression of the LH secretion from the pituitary. Thus, the testosterone was lower, as well as the androgen receptor was blocked. And this dual mechanism of action actually led to a specific class of adverse events, which was typical for steroidal anti-androgens. Because of the lowering of testosterone, the typical ADT adverse events like loss of libido, loss of erectile dysfunction, loss of BMD was there. And because the testosterone was low, the incidence of gynecomastia and breast pain, which is because of the peripheral conversion of testosterone into estrogen, was not seen with the steroidal anti-androgens. And this is important because the next molecule, the first generation, have these typical adverse events. But these steroidal anti-androgens are not used clinically these days. The next generation was the first generation non-steroidal anti-androgens, which was in vogue for almost a decade or so, and have just recently become not the first line treatment. So these are pure androgen receptor blockers. They do not have any central progestational effects. And because of this pure action, they actually block the androgen receptor in the hypothalamus and pituitary, thus blocking the negative feedback loop, increasing the LH secretion, and thus increasing the circulating testosterone in the body. And because of this increased testosterone, they were theorized that if used alone without other ADTs like orchidectomy or LHRH analogs, they will preserve libido, they will maintain erectile function, they will maintain BMD and muscle mass. But this increased testosterone was converted into estrogen in the body, leading to a typical adverse event of gynecomastia, breast pain, and breast tenderness, which was not seen with steroidal anti-androgens. The forerunner molecule of first generation NSAs is the bicalutamide, which is a competitive inhibitor of androgen receptor. Now, androgen receptor, the native molecule which binds to AR, as we've discussed earlier, is dihydrotestosterone. But the affinity of bicalutamide as compared to dihydrotestosterone for AR is 50 times lower. Bicalutamide also has some partial agonistic activity. It's not a pure antagonist. It has some partial agonistic activity at the androgen receptor also. As we have discussed, it blocks the feedback loop. Thus, it is converted in peripheral systems into estrogen, and this increased amount of testosterone converting to estrogen leads to gynecomastia and breast pain and tenderness, which we have discussed. Moving on to pharmacokinetics, the bicalutamide has a very high bioavailability and the drug is well absorbed. There is no relationship with food. It has two enantiomers, the R and the S. The R is the active one. The half-life is 7 days, which allows for an OT dosing. It is extensively metabolized in liver, and the pharmacokinetics are not affected by renal or mild to moderate liver failure, and there is no need to change the dose with mild to moderate liver failure or any amount of renal failure. However, severe hepatic failure needs dose reduction to half. So it was typically used in 2 doses, the 50 milligram dose, which was inadequate for a total castration, but was typically being used as a maximal androgen blockade in addition to orchidectomy or LHRH analogs. And the other dose was 150 OD, which was considered the castration dose, which was used either to prevent flares in the initial 2 to 3 weeks with GnRH analogs, or was considered to be adequate dose for patients with M0 disease as an adjuvant therapy with radiotherapy. Those who are receiving radiotherapy, 150 mg OD can be given as an adjuvant adequate castration dose, but it was considered inferior for patients who had metastatic disease, so it was not used alone in those patients. So adverse event profile, if you look at the class effect of this drug, if they're used in monotherapy, they typically have very high incidence of gynecomastia and breast pain and tenderness to the tune of 40%. And for the molecule itself, the bicalutamide, it has about a 10% incidence of diarrhea and can cause eleptic derangements. However, it usually resolves on its own. Now, comparing the other 2 molecules, which are not very commonly used in India, the flutamide and the nilutamide. The flutamide has a much higher incidence of diarrhea and liver failure as compared to bicalutamide, whereas nilutamide has a typical adverse event of poor light-dark adaptation, which is not seen in bicalutamide. And as far as drug interactions are concerned for bicalutamide, there are 2 major drug interactions. First, it is a CYP3A4 inhibitor. So any drug that is metabolized by CYP3A4, example, midazolam, nifedipine, lovastatin, these drugs will be increased in concentration and you have to take care of that. And the second important drug interaction is that bicalutamide tends to displace cormorin, like warfarin, from its binding sites. Thus, it will increase the dose or the active it will increase the amount of warfarin in the body, and the patient can have excess hemorrhage. And it has been reported that care is advised for regular monitoring of PTNR in patients who are on warfarin. Otherwise, it's not a problem. So for warnings, there are 4 major warnings for bicalutamide. Severe hepatic injury and fatal hepatic failure has been reported, and regular LFT is recommended. Hemorrhage can occur in patients on warfarin. Gynecomastia and breast pain, if it is used alone, is a common thing. And hyperglycemia with LHRH analogs was noted. For clinical prescription, the dose is 50 or 150. No addition to food, can be taken at one set time of the day. Renal dysfunction, there is no need to change the dose, and no need to change the dose in mild to moderate liver dysfunction. However, severe hepatic failure, dose reduction is required, and periodic LFT and monitoring PTINR in patients on warfarin is recommended. Currently, it has recently become not obsolete, basically, because first-line treatment has now been changed. And it was initially being used for maximal androgen blockade and for prevention of flares. Currently, it can be used in patients who have had RP and are receiving adjuvant RT, because some of the older trials have given bicalutamide 150 alone as the ADT in patients who are receiving salvage or adjuvant RT. That is probably the only thing now. So just a brief comparison of the 3 molecules. The flutamide requires TDS dosing, whereas both bicalutamide and nilutamide needs single dosing, and the special adverse events we have discussed. Now, moving on to the second generation non-steroidal anti-androgens, which are the drugs or the first-line treatments for metastatic hormone cancer prostate these days. And as compared to the first generation, they have pure antagonistic action. There is no agonistic action with these molecules. They have stronger binding affinities to the androgen receptor than the first generation, and they block additional steps. Thus, they are actually more effective than the first generation non-steroidal anti-androgens, and they were found to be effective in CRPC states also. So the first molecule for second generation NSAA is enzalutamide. It is a competitive inhibitor. It has 5 to 8 times higher affinity for androgen receptor than bicalutamide. There is no partial agonistic activity. And besides blocking the androgen receptor, it inhibits the nuclear translocation of the hormone androgen receptor complex into the nucleus, as well as binding of this complex to the DNA. Thus, this blocks additional steps and is more effective than the first generation one. One important additional action of enzalutamide is that it has additional GABA A receptor antagonistic action and has higher possibility of crossing the blood-brain barrier. And this has been theorized to cause seizures, which we'll be discussing a little later in the presentation. For the pharmacokinetics, has two major metabolites. The N-desmethyl enzalutamide is the active metabolite of enzalutamide. Enzalutamide has a rapid oral absorption. Within 1 hour of administration, almost whole of the drug is absorbed, and it is not affected by food. The half-life is about 5.8 days. It is excreted primarily by hepatic metabolism, and there is no need to change dose with mild to moderate liver failure or renal failure. One caveat though, patients with less than 30 ml GFR, it has not been tested, so safety is not ensured. Now, for the adverse event profile of enzalutamide, hot flashes, fatigue, arthralgia, back pain, the typical ADT adverse event profiles have been noted. Enzalutamide with enzalutamide also. For the adverse event of interest for this particular molecule, now seizure was discussed as one of the very important adverse events, but it has been now found that the seizure risk is only 0.6%. And we'll discuss in the next slide that it is not increased because of enzalutamide. The another very important adverse event profile of all the second generation non-steroidal anti-androgens is fatigue and fractures, and the incidence is quite common, 25%. So coming to seizures, higher blood-brain barrier penetration and GABA-A antagonistic activity was postulated to be the cause of seizures, and both enzalutamide and apalutamide were considered to be risk factors for causing seizures. But recent trials, the upward study, has shown that even in patients who are at increased risk of seizures, the incidence of seizures in patients receiving enzalutamide versus not receiving enzalutamide is almost same. So enza is not contraindicated in patients who are at high risk of seizures. But if the patient develops a seizure when he's on enzalutamide, it is recommended to permanently discontinue enzalutamide. For the drug interactions, now drugs that affect enzalutamide is metabolized by CYP2C8 and 3A4. So drugs that inhibit these cytochromes, that is itraconazole, gemfibrozil, and other drugs, are going to increase the concentration of enzalutamide. However, no toxicity has ever been reported. It's considered to be relatively safe. Whereas drugs that induce CYP3A4 or 2C8 will reduce the concentration and will make it ineffective. So rifampicin is an inducer of CYP3A4, which is going to reduce the concentration of enzalutamide. Now, drugs that will be affected by enzalutamide, enza itself induces both CYP3A4, 2C9, and 2C19. So drugs that are metabolized by these cytochromes will be reduced in concentration. Typical drugs commonly used are midazolam, warfarin, and omeprazole. The dosing of these drugs may need to be changed. Warnings and precautions. I've taken these from FDA warning list. The seizure incidence is 0.6% and discontinue if a patient on enza has a seizure. PRES has been reported very rarely, but if the patient has posterior reversible encephalopathy, it needs to be discontinued. Where 0.1% chances are there of hypersensitivity, typically edema of the face, skin, we need to discontinue enza. There is a 3 to 4% incidence of ischemic heart disease and ischemic events like CVA. If there are grade 3, 4 adverse events, they need to discontinue it. But for grade 1 and 2, you can continue and modify the dose. Falls and fractures have been reported, and the patients need to be evaluated. For the clinical prescription, 160 mg OD is the dose, no relationship with food, and there is no need to change the dose with hepatic or renal dysfunction. The next molecule in the second generation non-steroidal anti-androgens is apalutamide, exactly same mechanism of action as enzalutamide, but it has a lower central concentration. So it was theorized that apalutamide will have a lower incidence of seizures as compared to enzalutamide. The bioavailability is 100%. There is no relationship to food. Active metabolite is N-desmethyl apalutamide, almost exactly similar to enzalutamide. But there is a one typical adverse event with apalutamide that is not noted with enzalutamide, and it is skin rash. The incidence is pretty high. It's 30 to 40% of the patients are going to have skin rash with apalutamide. The rest, all the adverse event profiles are same. Even the drug interaction is same because both enzalutamide and apalutamide work on almost similar mechanism of actions, and it is same for apalutamide. But the warning and precautions, there is no incidence of PRES with apalutamide, but there is a chance of having severe cutaneous adverse reactions. Example is Stevens-Johnson syndrome or drug reaction with eosinophilia and systemic symptoms. If the patient has severe cutaneous reactions, apalutamide needs to be discontinued, but majority of the patients will have low-grade rashes that can be managed conservatively. So clinical prescription for apalutamide is 240 milligram OD dose. There is no relationship to food, and there is no need to change the dosing with renal or hepatic dysfunction. The last molecule is darolutamide. The darolutamide does not have any GABA A antagonistic action, so it was theorized that it will not cause seizures, and it has an additional progesterone receptor antagonistic action, but the importance of that action is not yet known. So availability, the darolutamide is only, the bioavailability is only 30%, and it needs to be taken with food, which is different from all the other, or both the molecules that we have discussed previously. And the bioavailability will be 2 to 2.5 times higher if darolutamide is taken with food. And dose changes is also required with darolutamide if there is severe renal failure or moderate liver failure. The adverse event profile, darolutamide has a much safer adverse event profile with no specific adverse event that could be ascribed to darolutamide. It has a low chance of crossing blood-brain barrier, and a recent systematic review actually found that its tolerability profile is similar to placebo, except for an increased fracture risk. Everything else was actually very safe. So darolutamide, the drugs that affect the darolutamide is metabolized by CYP3A4 and P glycoprotein. So any drug that inhibits CYP3A4, like itraconazole, is going to increase the concentration, and any drug that induces CYP3A4 is going to reduce the concentration, like rifampicin. One important or a different drug interaction, that is that darolutamide inhibits BCRP, OTAP1 and B1 and OTAP1 B3 enzyme. Thus, it increases the concentration of its substrates. One drug that is affected by this is rosuvastatin, which will be increased in patients who are on darolutamide. Warnings and precautions are fairly low because no specific adverse event with darolutamide has been reported. The seizure incidence is only 0.2%, and rest of the toxicity is similar as compared to the other two molecules of the same class. For the clinical prescription, the dose is 600 milligram BD to be taken with dose. You have to reduce the dose to half, that is 300 milligram BD if the GFR is less than 30. And you have to reduce the dose to half, that is 300 milligram BD, if the patient has child FUG B or C class hepatic failure. Just the current recommendations for the second generation non-steroidal anti-androgens, I've just tried to put it simply in this slide. Enzalutamide, with the recent EMBARK trial published in 2023, has been approved in patients with M0 who have received radical treatment either in form of RT or RP, have BCR, which is high risk based on the definition of PSA doubling time of less than 9 months. And enzalutamide has been shown to improve disease-free survival and has been approved. Apalutamide has been recently tested in APA-RP trial published in August last year, but has not been approved yet. All the three molecules are approved in non-metastatic CRPC settings. All the three molecules are currently first line of treatment for metastatic hormone-sensitive prostate cancer. Now, comparing these NSSA, comparing the second generation non-steroidal anti-androgens, they have almost similar incidence of adverse events, except the enzalutamide is with seizures and press, and apalutamide for rash and seizures. Even the total all other adverse events are almost similar. And comparing the clinical prescription in one slide, both Enza and EPA, single dose, no dose modification is required, whereas darolutamide needs BD dosing with food and reduce the dose to half if GFR is less than 30, or patient has child FUG B or child B class liver failure. A newer drug has been recently approved in 2022 in China. It is resvilutamide. However, it's not approved by FDA or EMA. It is also a second generation non-steroidal anti-androgen with an exactly similar mechanism of action as compared to Enza, EPA, or Daru. It is proposed to have lower blood-brain barrier concentration, crossing abilities, thus proposed to have lower chances of seizures, and has been effective in metastatic and castrate-resistant settings and is being used in China, but is probably not available elsewhere. And a lot of new androgen receptor blockers are currently under evaluation or preclinical studies, and we'll be seeing a lot of them in recent future. Thank you.
Thank you, Siddharth, for this excellent talk. And we can have our chairpersons to pitch in, and they can give you their views about androgen receptor blockers. Dr. Himanshu is there, and Dr. Nayak, Dr. Himanshu, Dr. Amitabh. Is anybody there?
I think Bora Siddharth has actually done a very extensive and elaborate presentation on androgen receptor blocker. Actually, there are some few important points. I was not very aware till the last moment, till now. Actually, the important thing he said, actually, the risk of seizure is not increased with enzalutamide, which is actually, it was known to me just right now. I didn't know. I was thinking risk of seizure is more with enzalutamide, but that's very important information. He said enzalutamide can be given in patients with a risk of the seizure only when if they develop seizure, then we stop it. That's a very important point. And as far as the other anti-androgen blockers are actually concerned, bicalutamide, to my mind, actually there is no major role, and it currently should not be used as a monotherapy in metastatic setting. And as you rightly pointed out, it can still be used in patients with localized prostate cancer, those who are opting for ADT and RT, it's still used. And I don't know whether abiraterone actually was not considered and not discussed in this particular presentation, but I would like to ask Siddharth if he has actually gone through this. For abiraterone, there is some discussion regarding whether when you give abiraterone, there is a discussion regarding the dosing. The standard dose is actually 1 gram daily. So there are other papers which actually consider giving abiraterone with 250 milligram or 500 milligram with the fatty diet. Siddharth, have you gone through the any papers to give your view on this?
Sir, I've just superficially looked at this. I've not looked into detail, but probably there is a paper that shows that 250 mg OD with taking fatty food is similar, has similar effect.
Yeah. Okay. Okay. Amitabh and
Himanshu, Amitabh,
anybody can.
Dr. Syed, anybody wants to make a comment? Dr. Gautam.
Sir, hello.
Hi, Dr. Gautam. Yeah.
I'm Dr. Amitabh. Can you hear me?
Amitabh. Yeah, you're not visible.
Good afternoon, everyone.
Yeah.
So just regarding this abiraterone dose, that it's a basically randomized controlled trial. It was published in JCO long back, actually. And depending on that paper, there is a recommendation in NCSN guideline also. So the abiraterone can be given in 250 milligram once OD with fatty meal. And regarding enzalutamide, so we have seen a sudden fall also with the enzalutamide, and it is in this prescription also. And we have seen skin rashes with the enzalutamide in our patient. And like among all these newer hormonal agents like enzalutamide, apalutamide, and darolutamide, the enzalutamide is very actually toxic drug, especially for the elderly patients, because they are frail patients and they are having all these muscle loss and everything. So if they have myalgia, then it becomes very you can say difficult to tolerate these drugs. And I think darolutamide is the best one. If you'll see the Aeronaut trial, the side effect profile of the darolutamide was much safer, more safer than the placebo arm also. So I think the darolutamide is the way to go. But unfortunately, we don't have any generics available for the darolutamide. We are having only single darolutamide with the Bayers, and it costs very lot. I think 1 month of this darolutamide will cost around 1 lakh for patient. So when we will have all these generics darolutamide, then I think that would be the most preferred drug among all these NHAs. And apart from that, he has covered excellently all these NHAs. He has described everything about all these enzalutamide, apalutamide, and darolutamide. I have nothing except to tell them.
Siddharth, coming to the customization of the therapy, our residents always come whether should I give him abiraterone and Vasilone or enzalutamide or darolutamide, which should be the given for which subset of the patient. Generally, we say if it's a diabetic patient, we can avoid prednisolone, we can do enzalutamide. So there is a specific subset of the people we can identify where we cannot give abiraterone, where we cannot give enzalutamide or something like that. Can you give some brief overview where one drug scores over the other in terms of the patient profile or comorbidities?
Sir, things that we can look about are that patient is diabetic, so abiraterone would be a problem. Other than that, previously the seizures was one of the reasons for not choosing, but then now it is no longer there. But these are the main things, sir, that we can look for.
But Bora, I think if I can take that question actually, when you consider giving these drugs, there are important things that you should see. What are the risk factor? What are the comorbidity? that the patient is having, and also at the same time we look at the cost.
Yeah.
So only per se having a diabetes, if the patient is well controlled and not on multiple OHA, abiraterone can still be given, though we still tend to avoid abiraterone because it's the patient has to continue on steroids. But abiraterone can still be given if the patient is well controlled diabetic, maybe on diet or maybe the one OHA still can be given. Because among all the drugs, I think abiraterone is less costly and it's easily available. So the thing that you need to see, as till now we are actually looking at the seizure part, and if the patient is having a history of seizure on some neurological issues, then you tend to avoid enzalutamide and give abiraterone. However, there are no studies till now that whatever study has been done head-to-head comparing ADT with one of the ARPI, there has not been found any difference between the ADT and ARPI vis-a-vis their overall survival or disease-free survival. Only when you see all the side effects and then the cost, you tend to decide which one you need to give. But Amitabh has actually touched upon a very nice point. Darolutamide seems to be more safe drug among all this, but unfortunately it is very highly costly. Maybe with time, when the darolutamide, the cost comes down, maybe people will prefer a darolutamide over all these drugs.
And
So
one
important question, please. Yeah, Gautam, go ahead. Yeah.
So one more point, choosing first AB over ANJA is sequencing is better in term of the, if we sequence AB first and then ANJA, then it would be, more durable response, and the response of the sequencing is better than vice versa, opposite.
Do you think that is the thing,
Yes,
Dr.?
yes, AB and ANJA, it's true. If you are giving AB first, then ANJA, that's better rather than doing the reverse way, ANJA and then AB. That's true for AB ANJA.
And
But
further,
sequencing these
take
two.
into consideration the disease, like suppose entirely soft tissue disease, extensive disease, symptomatic, then people rush to the ANJA. That time it's good. Otherwise, if the fairly okay patient, then and well controlled diabetes, even I would prefer to give AB first, and then I would like to keep
It's most commonly used drug is the abiraterone actually nowadays.
Yeah.
Siddharth, any pharmacokinetics where to take the drug? Sometimes people will say you breakfast le lein, ya fir we can take in the night or something. Sometimes they will say some interaction with the drugs. So is there anything, and that there is no pharmacokinetic study available at that where will the peak dosing will happen in terms of abiraterone?
Sir, about the pharmacokinetics, both ENZA and EPA, they have a very long half-life. So they will achieve a steady state plasma concentration, and once that is achieved, it does not matter. They can fix one time and they can keep on taking that drug at their own convenience. There is no relationship to food also. But for darolutamide, BD dosing is recommended, that too with food, because the availability is only 30%. So darolutamide needs to be taken BD with food, whereas for ENZA and EPA, it does not matter. Just fix a time and then keep on taking it.
But there was one question with regards to if the patient does develop gynecomastia and breast pain, what should be given?
So that is a standard treatment. You can give radiotherapy or tamoxifen for that. I've made a slide for that. Just a second.
That's fine. You can just.
Okay, sir. For the treatment for gynecomastia, the hormonal agents have been approved, like megestrol, estradiol, methoxytestosterone. Even this venlafaxine and fluoxetine, they all have been approved for that, and tamoxifen has been used. Other than that, if the patient develops RT, radiotherapy, prophylactic radiotherapy has also been given for gynecomastia.
Yeah, so any estrogen antagonist, basically, that has to be recommended.
Thank you, Siddharth, for the excellent talk, and all the chairperson, Dr. Nayak, Dr. Amitabh, Dr. Gautam, for their insights. And I think, hope we had a good program, and the resident must have enjoyed it. So I would like to request Dr. Rishi for the final concluding remarks to our participants, and as well as the residents who are still logged in. And we had a good, successful program. We have more than 100 people joining on a busy Republic Day on a holiday. And I think it's a success, and we can have a feedback from the residents later on after this program, so that we can have more activities like that, or should not have it, and what should be the best day and date time of the day. Dr. Rishi for the final remarks. Thank you.
Thank you, Dr. Bora, for conducting this and taking the responsibility here. If there are any comments by the residents, they can still write in the chat box, or you can also send to me personally on my email. And even from the faculty, I would like that some feedback is given to us for any changes that they would like to see in the subsequent programs. One thing for the residents, we are now going to have a live mock examination in the North Zone in the month of July, 5th and 6th of July. So all those second year and third year residents who want to participate in the mock exam, they can start registering with us. We would be sending the link very soon. Other than that, there are other activities being planned in the North Zone, which you are getting regular updates from the WhatsApp group as well as the emails. The one international travel is coming up now, and then NZUSI Cares activity would be there in the probably in the towards the end of February or early March. With this, I think we will conclude the session here today. Thank you. As Dr. Bora also said, we were consistently touching 100, and there were actually more who had joined on YouTube also. So we had a very good attendance today for any web meeting that we hold these days. So thank you once again, all the faculty and the residents. I hope to see you once again in our next activity. Thank you very much.
Thank you, sir. Thank you so much.
Thank you, and congratulations, entire team, including Bora sir, taking lead.
Thank you.
Bye-bye.
Thank you. Thank you.
Happy Republic Day, everyone. Bye.